likely to die in a nation or a state with no organized trauma care system than in which with an organized trauma care system. So if 100 people are now, for example, if 600 people are dying in the roads, we can actually decrease it to 100 if we have a resourced emergency care system for potentially treatable injuries and potentially fatal cases. Now, I mentioned about geography. I underlined the word geography. Why geography is important here? Because in emergency, if you have a proximity, geographical proximity to a facility, that actually means time. If you have a heart attack in front of, or if you have a myocardial infarction in front of emergency care department of AIMS or Trivandrum Medical College, you have a higher chance of survival because the treatment is available just near to you. So geography is time in emergency, and time is life in emergency. Yesterday, Vishwanath sir told that like emergency physicians are time masters, and time in emergency means life. And that time matters at the institution level. This is the red area in AIMS Trauma Center where Sanjeev Boy sir orchestrates at this that red foot mark, and each of the persons standing on each of these foot marks know what they do and how they do, and at the minimum time taken for that. And that's why time matters at the institution level at the red area. Similarly, the time matters at systems level also. It's not that when you reach someone to the hospital, there only the time starts. No. If you have an incident, you have an event of emergency, or you have a heart attack, your time starts there. So the system has to function in a time-bound manner to ensure that people live. So this is my favorite slide, and many of you know. So that because just wait 1 second. So in my 12 years of working in emergency, the closest analogy of an emergency care system, what I saw is, or emergency department, what functions emergency system, what I know is about F1 pit stop. That is Formula 1 pit stop. Formula 1 pit stop is a place where every second matters. Because if you lose a second due to your inefficiency, you lose your race, just like in emergency. You lose the patient, you will lose the race if you lose time in Formula 1 pit stop, as you see. So please play the video. So I just want to show how time matters in this and how improvement can happen in time. Please play the video. So this is a Formula 1 pit stop in 1950 at Indianapolis.
But Holland comes in for a pit stop. Time to refuel and change tires. Lou Moore himself changes the tires. Only 4 crew members, including the driver, are allowed to work on the car. It's a tense time. Holland stays in his seat, anxious to get away. Let's watch.
You see they are changing 2 tires. The person who is, just imagine these are postgraduate students or someone in the emergency care. So someone who is doing changing the tire 1 is coming here to change the tire 2.
The tires are changed at last. A crewman polishes the windshield as Holland moves away just 67 seconds
67 seconds. That was a record at that time. 67 seconds was the fastest Formula 1 pit stop at that time. Now coming to 2013 Melbourne. Here we are going to change 4 tires. And the time taken that for is 1.6 seconds. And imagine the activities involved in that. The car stops, someone lifts the car, you actually unscrew the tire, 1 tire, take it out, you put another tire, screw it. Just saying that took me 10 seconds. But imagine that is done in 1.6 seconds. How did they do that? That's how they know that everyone know that what they are supposed to do. Everyone know that what is their duty. And the whole orchestration happens just in signals. That's how systems work. That's how emergency care work in the hospital, and that applies to the system also. So now, next slide. Okay. Now looking at the emergency care at primary level, as I said, this should be part of the system itself. It cannot stand out in that. So yesterday, Venkit sir presentation told that what are the packages in the health and wellness center, in which emergency care is one of the major package. So Government of India has come out with a guideline on what is to be done at Ayushman Bharat Health and Wellness Center, and an operational guidelines for emergency care facility. And now WHO CCET, AIMS Trauma Center, is actually doing a pilot of this in Rajasthan, and a bigger study with ICMR on looking at how to integrate emergency care at the primary level itself. So that's something which I'm not going to the details of. As I said, it's one of the package in emergency, in the service packages of Health and Wellness Center. So one thing I will just say is that when it's taking at the primary level, when you go at the primary level, there are basic concepts of primary care which need to be stick on even in emergency care also. It's just not about giving the treatment. It has a community participation part, and also looking at the community awareness apart from giving the treatment. So at the community level, we would be having a promotive component, you will have a preventive component, you will have a curative component, a lifestyle modification component, and socio-environmental component attached to this when we take primary emergency care to the primary level. And yesterday Tata Trust has presented beautifully that how they do it on the field, so I am not going to the details of each of this. So when it comes to management of health emergencies in a healthcare facility at the primary level, that primarily would consist of first is assessment and triage, followed by an early transport, and if possible, after possible, first aid and stabilization. Remember the word possible first aid and stabilization. ABCD management if a first responder is available, and follow up the emergency cases when they are transported to the institutions. Then community-based or facility-based rehabilitation, mock drills, and followed by development of parallelly a development of a referral directory. Now, having said that, there is always a catch when we say emergency care at the primary level. Because there is an increasing tendency to see that you set up small facilities where you give an emergency care, stabilize and go. It's not just like a referral in any other system. Because a referral here means you need to have an appropriate referral. Because a head injury patient on the ground need not to be taken to a primary care center and referred from there. Because you know that for head injury, primary care is not, the primary care health center or health and wellness center is not enough for dealing with that. So that should be part of a system. It cannot be an isolated system where everyone goes to the primary care or primary health care center and they get referred. It's not like that. It forms a part of, you need to know where the health facilities are, each of the health facilities are, what can they do, and at what quantity, and what can they take. And you need to understand that what is the time taken for transporting a patient for each of the health facilities to the required health facility or appropriate health facility. For that, how do we do that? Because as I said, you need to remember time is life. Let me give you an example of how we did for this while we were developing the action plan, how we did for that. And how this number of 315 ambulance of Kanib arrived. So this is Ernakulam, just an example for the Ernakulam district. You map all the roads in that. And when we say all roads, it means the other roads also. Because national highway and state highway constitute only 4% of the whole network of 6.4 lakh roads 4 lakh kilometer roads in India. So for 6.4 lakh miles of roads in India. It's not kilometers. So this is a road network for the district that involves the other roads also. Because other roads are relevant, not only road accident, it is relevant in all emergencies because you take the patient to the hospital through the roads only. So you do an extensive mapping of the healthcare facilities available there, overlap with the road facilities available, then do black spots. This black spots, this for road accident, it can vary for other emergencies, there can be black spots can be different. put the data into software called ArcGIS or maybe QuantumGIS. There are many other softwares for doing that now. And there are many things called vector-based analysis. There is called network analysis. Network analysis is something which we used a lot. And proximity analysis or buffering. By doing that, you know that which health facility is best for actually strengthening. Which health facility is to be strengthened to ensure maximum care, and where the ambulance need to be placed to ensure that the patients are getting emergency care when it is required. So we can add many components to that. We can add fire station, you can add schools, you can add many other facilities to have a mapping in a good way. Then we can have other natural disasters, everything can be mapped in this, floods, and what is the benefit is that you can understand what is the difference between traveling time taken, or what's the kilometer difference between all the institutions at level 3 or level 2 institution, and identify if you have an ambulance placed in some place, what would be the time taken for an ambulance to go, what would be the time taken for other vehicles to go, and ambulance can be set, the speeds can be set like 60 km per hour with 30 seconds delay in each busy junction. We have to, this software is a beautiful software in which we can play many things. So we identify where to place the ambulances, and we identify which hospitals to be strengthened to ensure that people get an effective referral also. So there's a small story in that 2012 when we are doing this thing. So we had an opportunity to meet Sanjeev Boy sir for the first time at that time. Then we realized that what need to be in each of these institutions, so ensure that these facilities are there. So we were able to do it based on the requirement of each of the facilities, and taking up from the WHO essential guidelines, we were able to develop a action plan. And before that, what helped us 2014, as Tajan sir said, we had a first team which went to AIMS for training to understand that what is required for the institution. Cyril sir, Srikanth sir, all was part of that, and that team actually, and Tajan sir was, so that team did a detailed analysis of this thing, and we developed the essential trauma care. And why it is important is that you can understand that what is required at each level. We realized that we need to train about 13 lakh people in first responder at the primary level, then 315 ambulances based at the strategic points, and 33 hospitals. That includes a definition of the level 1, level 2, 3, level 3 hospitals. And what is the requirement? Based on what we learned from AIMS Trauma Center, we identified what is the requirement of each of the facilities so that we can budget that 122 crores is the amount required for strengthening the emergency care system in the country. And from there, like say, as it is told that if you want your dreams to come true, don't sleep. I am sure that the people like Vishwanath sir, Srikanth doctor, Tajan sir, Cyril sir, everyone's actually decided not to sleep to come make this dream come true. And that's the realization of this, what's happening here. And thanks to the efforts, there are great efforts in that. So thank you very much. And as I said, reiterate that primary care system need to be the part of the whole system to ensure that adequate facilities are available for it, and we cannot be a standalone. Thank you very much.
Thank you, sir.
Thank
Now
you.
we will be having a
Any questions? We will finish now only.
So I feel road safety transport department also must be involved along with medical doctors.
Yeah. Can I respond to that? Yeah. Very good point. That's why UN Decade of Road Safety actually looks at the safe system approach. It's not just the like medical model for that. There's a safe system approach where the system needs to be safe. That includes starts from the person who is driving or person in the vehicle, and the immediate things like safe vehicle need to be safe. We need to have a safe roads, safe road users, but still, because still 70% of death occurs in vulnerable road users. Then comes the safety environment. All this comes together. It's not just the one component of healthcare delivery. We are only part of what we call as a post-crash response in the 5 pillars of road safety. But there are pillars which need to be taken care of. That's why WHO is collaborating with the Government of India, and we are conducting a national stakeholder workshop in April on identifying especially for road safety. So these are areas we actually need to think of. That's why Manasara Kishan Kumar sir is there. Government of India is bringing out a injury prevention strategy in which we have elaborated the safe system approach to other injuries also. That includes falls, that includes elderly injuries to elderly, child injuries, all these things. Government of India, with leadership of Kishan Kumar sir and Manas, has taken this safe system approach to the other injuries also. So systems needs to be safe. Our role is limited for a post-crash response, but we as the health professionals and concerned about this, we need to promote and take other departments on board to develop this. Thank you.
Any other questions?
Just a comment on, not a question to Ashil, is I heard our colleague speaking about the disconnect between the various stakeholders of saving lives. So Ashil has put very nicely, all stakeholders, 5 pillars of road safety must be acted. One of the beautiful examples of a road safety, if Dr. Vishwanathan also will agree, it starts from Rajasthan. Rajasthan Road Safety Cell, I think Dr. Nidhi is here, Nidhi, she was there, so that team has come. So they have in their own road safety cell, they have doctors, okay? There is police people sitting there. There is a PWD guy sitting there, PWD engineer who makes the road, and also the other vehicular people are also, they're sitting there, the traffic guys. So, and they keep on monitoring the data and analyzing the data and giving the strategic action points to various stakeholders. Do 3 monthly meetings at the road safety cell in Rajasthan, even in the district road safety cells. So they do a beautiful integration model. So that is the answer for most of the states. It should be like that, sir. Including, we'll speak in a later. You can also create similar models. Road safety is very important. Okay, similar models for monitoring for other emergency conditions can also be done by the district collectors. So similarly, so we'll take the discussion further because I think brevity of time we should pause here. Thank you. Thank you very much for your presentation.
Yes, sir. Thank you, Dr. Rashid.
Thank you.
Now I'll call upon Dr. Akshay Kumar, Associate Professor Emergency from AIIMS, New Delhi, for the presentation on quality assurance and improvement in emergency care. Dr. Akshay Kumar, please.
Hello, can you hear me? Yes. So thank you all for this opportunity. So I'm going to shift gears a little bit. Let me introduce myself. My name is Dr. Akshay Kumar. I'm an associate professor in the Department of Emergency Medicine at AIIMS, New Delhi. And I'm going to shift gears a little bit and talk a little bit about quality and quality at the institute level, at the departmental level, at the local level, and how we can ingrain quality improvement in our local areas of work, in our department, in our institute is what I'm going to talk about in the next 10 to 15 minutes. So let me start by talking about quality. So there was a definition by the Institute of Medicine in 2001 which talked about quality. So quality has these 6 pillars. So the most important thing is safety, patient safety. First, do no harm. So you should not do any harm to the patient, that is safety. The second component of quality is timeliness of care. So right patient, right time. So give the patient care in the right time, that is timeliness in care. Efficiency in care, which is slightly different, that is not wasting resources, not wasting time of the patients, not wasting human resource. equity, that is equal care for everybody, whether the patient is rich or poor, or the patient has, is from an urban land or a rural area. Effective care, that is evidence-based care. So the quality, the care should be evidence-based. It should be, that is very important. And most importantly, all quality of care should be patient-centered. So it is around the patient that we should think, wherever we think of healthcare, we should think the patient should be at the center of healthcare, and that is a very important point about quality. So as we talk about quality, there are a few terms which sometimes we sort of replace with each other, and it is very important to understand. So there was, I'm going to go to this next slide, which is more useful. So Dr. Joseph Juran was the gentleman who in 1970s described the quality, triology. And he said about quality planning, quality control, and quality improvement. So what he was mentioning, quality planning is the overall umbrella. It is about developing, all what we are talking about is quality planning right now, system, framework, policy, resources, coordination between the ambulance system and the primary health care and the district hospital, medical college, tertiary care centers, accountability, execution and design. So that is the whole umbrella of quality planning is what we're doing, and the whole conference is about. Quality control or quality assurance is the standard guidelines and protocols and the accreditation or the checklist or the inspections which are happening. The NABH body is a quality assurance body. Quality improvement, on the other hand, is a continuous effort by the frontline staff in order to make things happen on the ground. So my talk is going to be focused on quality improvement is what I'm going to talk about. So quality improvement is the data-driven, local data-driven improvement of your local system. For example, you want to improve the door to ECG time in your department. You want to reduce the door to OR time in your department. So it is the local data which you have to collect, and you have to find the problems and you have to correct them in a systematic manner is what quality improvement is about. So these are the three triology doctors described. So first start, so if you see the left side of the slide, this is where quality planning is. Then is the time of quality control. So you do some PDSA cycles, sorry, is this working? Yeah. So the PDSA cycles, they, from the zone of original quality control, using quality improvement, you can take the quality control to the next level. So that's how it all works together. So quality planning on the left side, quality control on the right side of this vertical line, original zone of quality control, and you do PDSA cycles, you follow the quality steps, and I'm going to talk about the steps in my later slides. So these are examples of quality assurance. These are guidelines, the national quality assurance guidelines. We know the American College of Physicians, they have guidelines, policies, and these are all quality assurance documents or quality control documents. So what is quality improvement is what I'm going to talk about more. It's a form of a clinical process and a managerial innovation. So you use local data to bring about immediate positive change in your unit, in your ward, in your hospital, in your institute, and it combines scientific knowledge and application to the system. So it is internally driven. The quality improvement is internally driven as opposed to quality assurance, which is driven by regulatory and accreditation agencies. The focus is on improving the system and process of care and preventing errors. It relies on improving the processes. So you have to look at the processes. What is the arrival time of the patient to the emergency department? What time the patient was seen by the first doctor? What time the patient got the ECG done? So you look at the smaller processes, and that's how you. So it relies, and it is a continuous and internal strive by the frontline staff in order to make it happen. So I'm just going to keep it, this is something we looked at. So, and how do we translate knowledge into practice, okay? So we need knowledge, definitely. We need to learn, we need to go through MBBS, BSc, we need to learn, we need to acquire knowledge, we need to acquire skills, skills of surgery, skills of emergency medicine, skills to, skills of interpreting an ECG, for example, competency-based learning, research, we need to learn research, we need to learn other medical education, all those things, and obviously which will all improve clinical care. But is all of this actually translating into the outcome what we want? Is all of the training translating into the outcome what? Unfortunately, no, at some points. We already know that, stroke should be treated within 4.5 hours. But is that actually happening on the ground? So we want to fix the gap. So the missing piece is quality improvement. So between the 4th and the 5th, so that is where the missing piece is, and that can be bridged very well by a quality improvement process. And this is what, so I've made a small cartoon here. So this is where the tire hits the road. This is what you want to improve. You want to improve the patient to doctor relationship, and that is the most important thing. And I think that is why we are all here. We want to improve that. We want to improve the patient doctor or the nurse doctor, communication, treatment. And in order to do that, we need knowledge, we need a training, we need skills, we need infrastructure, we need policy guidelines. But we also need a missing link, which is quality improvement in order to be the best and serve our patients. So in a nutshell, making it happen is what QI is all about, making it happen, and not just helping it happen or letting it happen. So helping it happen will be quality assurance, which is all we're about, but making it happen on the ground where we need the frontline staff. So how do you make it happen? I'm going to talk. So quality improvement has a lot of dividends also. Before I talk about what is quality, how to do it, which is a full 1-day, 2-day workshop actually, we conduct quality improvement workshops. I started learning about quality improvement when I was, I got associated with the Department of Pediatrics at All India Institute of Medical Sciences, Delhi, and they were doing a lot of quality improvement work for maternal and child health, and that's when I started learning about quality improvement, and we started using that in emergency medicine, and it was used. So we saw that you could actually get a thesis, you could get a publication. So it is, how do we ingrain it and how do we use it? So that's Dr. Sindhu. Some of you may know her. She is a DM student of neonatology from AIIMS New Delhi, and she was the first one to do a quality improvement project as a thesis from AIIMS New Delhi. So she did 2 dissertations, quality initiative of implementation of golden hour bundle, and she did another on hyperoxia, and she actually received the gold medal at the National Neonatology Forum for her quality improvement work, which was an ICU based work which she did. So since then, in our department of emergency medicine, we started giving out quality improvement projects as research projects. So on the left, we did a quality improvement project with one of this was the first project as a quality improvement project, where we looked at reducing door to reperfusion time in ST elevation myocardial infarction patients. And we did a quality improvement project. We shook hands with the Department of Cardiology. We looked at the processes. We looked at where the problems were. We tried to look at the change ideas. We used PDSA cycles, plan, do, study at cycles, to make the improvement, make the changes, sustained the improvement, and brought about an improvement. So this was done as a thesis. The second thesis which we did was ensuring blood cultures and reducing door to antibiotic time in patients of sepsis. So this is the third one which was recently submitted, where we looked at improving first pass success rate in emergency endotracheal intubation. Quality improvement can also be, you can make poster and you can actually, so the residents out here who are looking out for a project, it's a great project to do, and you can present it in national, international forums. So both our projects which we did as thesis finally got published in BMJ. We have the strengthening emergency care systems and the strengthening sepsis care. Both of our projects got published. And these were some other projects which were not part of the thesis project, but were, so we looked at improving triage, and we also looked at advancing airway management. So it is a huge benefit for the emergency clinician. So how does it benefit you? It helps, empowers the clinician to improve patient care. So when you understand quality improvement, you become a different person. I mean, as a clinician, I remember, you start looking at problems differently because you can see what the problems are and you start thinking of how we can improve these things. So day-to-day solving by understanding care processes, that improves. So it improves you as a manager. It helps you grow as looking at smaller things. It helps you greater awareness of problems in the department. It teaches you leadership. You start working in a team, and you learn to put data to use, and that's what quality improvement is. So I'm going to give a quick example of what we did. So the point of care quality, this is the 4-step methodology of the point of care quality improvement. So point of care quality improvement was developed by the WHO Collaborating Center for Newborn Care at AIIMS New Delhi, Department of Pediatrics. And they developed a very simple 4-step point of care quality improvement. So first step is to identify the problem in your department, in your hospital, the district hospital, whether you are whatever you are. Let's say you have a problem of, the chest pain patients are not managed well, or the sepsis patients are missing their antibiotic dose, etc. You form a team. You form a team of people who are enthusiastic, that a resident, senior resident who is, who's very champion of change, and an enthusiastic senior resident or a junior resident who's involved. A faculty member should always be a part of the team, a senior person. And you write an aim statement, what do you want to change? And how much do you want to change? So what do you want to make? What improvement do you want to make? You assess, the step 2 is to assess the baseline data. So you start collecting data and you see, what is and you measure, what are you measuring? Let's say you are measuring door to first medical contact time. So how are you going to collect the data? Who's going to collect the first data point? Who's going to collect the second data point? So all those things you establish and you analyze the data. At what time do you see the waiting time is longer? At what time do you see the waiting time is not so bad? So you sort of analyze your system and then you think of change ideas. You test your change ideas using the PDSA cycles, plan, do, study, act cycles. I will talk to it briefly when I go through. And 4th step is to sustain the improvement, to see and talk about it, sustain the improvement over months after the. So this is an example of the thesis project which we did in the sepsis project which we did, and it was led by our resident who was doing the quality improvement thesis work, Dr. Charu. She's on the left side, and I was the mentor, and these were the team members who were part of this training of this QI project. And we did an analysis. So we did a process flowchart. We looked at all the steps. Patient arrives to the ED, patient gets screened, patient is identified as sepsis. So the ones we have marked in red are the steps where there was a bottleneck. So there was no screening tool. So the patients of sepsis were not identified properly. That was the problem. The other thing was patients were not marked. When they were identified, they were not marked, and checklist was not done. Blood culture bottles were not available. So we marked all the problems. And we also do a fishbone analysis. Similarly, you look at the other problems, people-related problems, process-related issues, place-related issue, policy-related issues, and you then think of change ideas. So we had some change ideas. We did on-site sessions. We started doing teaching sessions on-site, 7, 8 in the morning when the staff was slightly free because the number of patients coming at that time were little few. We developed a novel sepsis screening tool to identify the sepsis patients because this was not something which was there initially. And we had a checklist. We made a sepsis checklist which was being filled by the team inside when the patient comes in to and finally, this is once those change ideas were implemented, we actually collected the data for almost 15, right from January 2019 to December 2020, and we looked at how we reduce the door to antibiotic time. So over time, if you see, the door to antibiotic time started to reduce, and we had all these interventions which you can see in captions, and we over time the door to antibiotic. A small another project which we recently just finished and submitted was improving the airway management, and we did a fishbone analysis again, looking at the problems. We did a Pareto chart, another tool to identify the problems in your system. So we looked at why there was failure in order to intubate a patient in the emergency department. Why there was failure? So there was failure because of high secretions. So if you see, this is based on the 80-20 philosophy of Alfred Pareto, who said that 80% of the problems are because of 20% of the issues. So the 80% of the reasons were because of secretions, abnormal anatomy, and wrong patient. So as part of the change idea, we developed the these templates, we did some training, and we developed a post-intubation debrief form. And we saw improvement in first pass success rate, and a lot of peri-intubation complications also reduced as part of the quality improvement project. So my key points here are how to develop an ecosystem of quality. So develop a quality committee in your, this is my last slide. So develop a quality committee led by senior faculty or HOD. Establish key performance indicators for your department. So you have to establish what is important for your department. Is it the number of load of the patients? So like if you are a high performance department, are you looking at revisit rates to the ED? Return of spontaneous circulation rates after CPR. If you are a tertiary care center, first pass intubation, you can revisit rates of ED, percentage of patients admitted from ED per month. So you can define your own key performance indicator, and that is very important. So the other thing is digital data collection systems and audits will help to establish what needs to be improved, what needs to be corrected. M&M meetings are huge. The M&M meetings really help. And there is data, there is research saying that if you do a proper M&Ms, genuine M&Ms, it can help in identifying the gaps and in reducing mortality. Give QI projects as thesis projects. So residents can take it as thesis project that will sustain it in your department. That is how you can move it in your department, and important issues you can solve through the QI projects, through the thesis projects. And that will also help in behavioral and cultural change. So that will be some ideas which I think will help ingrain quality improvement in academic emergency medicine or in academic department anywhere we are working in the country. So thank you very much. That was all from me. Any questions?
Thank you.
Thank you.
Thank you. Any one question? Srikanth? Okay. Okay. Two questions then.
Thank you, Dr. Akshay. Excellent talk on quality initiatives.
Thank you.
As I was mentioning yesterday, our government also started this quality improvement initiative program. And we are also into the constant efforts of bringing quality into the emergency care. Not only emergency care, in other departments. But as you rightly pointed out, I think we should have the postgraduate residents taking it up from that level. And we have topics allotted to them so that they will be doing it at the micro level. Now, one important suggestion that I would like to have is that we will have a constant association between all the Institute of Medical Sciences, and we are also having a workshop on 23rd. The government, all over Kerala, we are going to have a workshop on quality improvement initiative.
Wonderful.
On 23rd.
Wonderful.
So, I think this is an excellent suggestion, and I would like to associate with AIMS.
Absolutely, sir. So, thank you, sir, for your comment. We are doing a one-day workshop, sir. One-day workshops in quality improvement. We've done that in Karnataka. We've done it in Delhi. 3 times we've done it for emergency medicine, focus for emergency medicine. Very happy to bring it to Kerala, and we'll be happy to handhold any projects that you're doing as well. So we can work together and develop, quality improvement projects in Kerala and different district hospitals in Kerala. It will be ideal. Very nice.
Thank you. Thank you, sir, for that excellent talk. I am Dr. Srikanth. I work as a surgeon at the district general hospital here. So my OP runs from 8 a.m. to 1 p.m. and I'm seeing about anywhere between 100 to 150 patients. So basically, we all are of the opinion that it should be the care should be patient-centric, and we should be doing maximum for the patient. but with such a heavy schedule, is there a guideline as to how much time should be given for examining a patient, or how much time or how many patients should a doctor see for within an hour or something, so that we can offer more? Many a time I'm not very happy with what I am doing. So is there a guideline?
So there is no quality metric that I remember as such, but lots of other countries which I know, they have developed, like in an hour you should give at least 10 minutes to a patient, at least 10 minutes to a patient in a busy OPD. That would be, but I'm not aware of any standard guideline as such. If there is somebody, I'd like to know, but how much time you should give to each patient, how many patients should we see in the OPD? I'm not sure what the right answer is. I know in triage, so there is a quality metric which is a standard, is that every patient who comes to the emergency department should be seen in triage within 10 minutes. That metric we know, that metric we have from the emergency standards. But for the OPD, I'm not sure how long they should be waiting. Is there a metric there? And obviously we need to develop a metric. If there is not, we develop a metric for the key performance indicators. You can set it up for yourself in your district hospital, in your medical college. You need to decide what is most important for if you think this is the problem, then you set a standard, you try to make it better.
So to put it before the government, we need to have some sort of guideline. You can say, okay, this guideline says that we should not examine more than so many patients in an hour. So you're actually depriving the patient of proper care.
Yes.
Only if you have some guidelines, then we can put across this idea to the government.
Absolutely. So we look at international guidelines and decide on how many patients we should see in an hour. Sir.
See this, Doctor, just a minute, one comment on that, then you can wind up. I know it is getting long. So first of all, you see that the matrix which is talking about definitely the gray area, but you have what is in your control that is why everybody should undergo, that is what is called as ED operation management. You cannot stem the flow of patients coming to the emergency room. It is emergency, and it is a right of every citizen to have emergency care. Right to emergency care. If you see US, there is EMTALA Act. In our country, Clinical Establishment Bill. So that is not STEM. But you can improve your processes, ED operations so much, because emergency care is not only the baby of emergency department. It is the whole hospital. It is failing if the patient is boarding more than 4 to 6 hours in the emergency room. 4 to 6 hours. That's it. Then just like a restaurant, you have multiple serving, then the customer has to go out. He cannot, put a blanket and sleep there. Something like that. So I agree with you. That's what the major point of this talk. You see, this is another initiative we have taken from WHO Collaborating Center, that starting quality improvement in emergency care. That's why Dr. Akshay has been, specifically he is speaking on that. While you are developing emergency departments across the country, I know it is a huge challenge. We started doing it, do it through research, do it through quality improvement research, which is doable, does not take any money. What are the problems you have on your emergency department for time-sensitive conditions? First, make them, triage time-sensitive conditions such as STEMI, stroke and trauma. MCH emergency, top 10 condition which kills the patient, that's it. And you will start saving lives. You see the changes happening within your own eyes, without spending a single penny. Within your existing system, within less human resource. Nobody can question the human resource. You must be thinking AIMS is resource rich. Resource rich with limited workforce in the ground, on the floor. They are single. When we started, myself, Dr. Amit and all we started, we are only one faculty, not more. Still the system was created. So just giving an example, So that's why do it through quality improvement is a beautiful science, and it really helps you with data. Data which saves life. That is the real thing, the real power of data. And you can use your own people for data collection within the emergency department. You don't have to employ anybody. We never employed any separate person. So that's why you have to motivate people. That is called a human-centric approach. Human factors are the biggest barrier for change, isn't it? You put equipment, supplies, everything you put still doesn't work. So that is the beautiful science we are bringing.
Thank you, sir.
In quality, that, and it complement what Dr. Vishwanath, Dr. Ravi is taking up for Kerala. Quality improvement is a big thing, and we are bringing, from WHO Collaborating Center, and also WHO has also a mandate for quality. So this we can push it big way, and Kerala can showcase that that lead. And Dr. Amit is also working on trauma quality. See?
Thank you, sir.
Congratulations.
Before winding up, just one comment, that is for any international research or multicentric research, there is the quality control and quality assurance. Quality control is happening at times like the audit, but the quality assurance is throughout the study to improve that. And there are set out guidelines also. So I think you have to look at that and can be included as guidelines, and I think we need the guideline for the improvement of emergency.
Absolutely. It's a complementary thing, ma'am. You need the guidelines, we need the standards, and we need QI to sort of help big
Thank
you, Dr. Akshay Kumar, for the
Thank you,
thought-provoking session. Thank you.
Thank you,
May I
sir.
call upon Dr. Amit Gupta,
Thank you, sir. Thank you.
talk on emergency nursing and nursing coordination. He is a professor of Division of Trauma Surgery and Critical Care in JPNATC, AIMS. He is the chairman of Academy of the Asian Collaboration of Trauma and the Honorary Secretary of Indian Society for Trauma and Acute Care. Over to you, sir.
Chairpersons, and thank you, Dr. Vishwanath, and all the organizers of the Kerala Emergency Medicine Summit for having invited me for a couple of sessions. The first one, and in fact, both my sessions have been made easy by the talk of Akshay. Thank you, Akshay, because quality, ultimately, we are all what we are looking through system interventions or through manpower interventions is improving quality of care. And one of these systems which we did way back in 2009, we started at the Apex Trauma Center, was the introduction of a nurse-based coordination and quality control system. Because empowering nurses, we think, takes off a lot of load from the doctors, which will be doing or will be performing clinical roles, and therefore, sort of empowerment of nurses improves the quality of care in general. So what I'll do in the next 15 minutes or so is take you through a journey of process of care in the Apex Trauma Center, how it happens, just a brief introduction so that you can understand the complexity of treating a single trauma patient and why coordination is needed and why a coordinated effort of the whole team, the doctors as well as nurses as well as the paramedics and technicians, is very, very essential. Then I'll go back to the background of the TNC system, when we started, what is the administrative structure at our place, who can be a trauma nurse coordinator, or what their roles and responsibilities are, and finally, how do they help in quality improvement, in disasters, and what are their salient roles and problems faced by them. So I bring you greetings from our Apex Trauma Center, which is a level 1 standalone trauma center at AIMS, but obviously it has cohesion with the main AIMS also. Structurally, it is standalone. It is a very high volume center, and generally we not only perform the role of a level 1 center in terms of patient care, but our mandate is also a lot of teaching and research, and also collaborations with states, international collaborations, community outreach. So we are sort of level 1 center in the paradigm of international level 1 trauma centers. So we have around 250 beds, out of which about 30 are there in the ED, which have got ED triage areas, red area, yellow area, and green area. And our processes are defined by the structure or infrastructure of our trauma center. That's very, very important. We also have the critical care units, the operating rooms which are there in readiness 24/7. Our admitting departments at trauma center are mainly 3. which is trauma surgery in critical care, which takes care of all the polytrauma patients, as well as torso trauma, vascular trauma, the orthopedic colleagues and the neurosurgery. Plastics also take up a few cases if they are required. We, as I said, we are a very high volume trauma center. It's just those 2 years of COVID that we went down a bit because our center was converted into a COVID center and we had to function out of the main AIMS. We admit around, that's our outpatient load, so we do not send our outpatients after they've been taken care at trauma center to the individual departments. Our follow-up clinics are in the trauma center itself, especially the admitting unit follow-up patients. We have annual admissions, roughly 8,000, and all these admissions are really critical in nature, so all the red patients and most of the yellow patients are taken up. Green patients can be discharged or referred to other hospitals. And we perform roughly about 7,000 or more major surgeries at our trauma center. Now, how we have divided our infrastructure is basically, what I'll be talking about is the processes of care within the trauma center or in hospital processes, and how nurses are actually helping us in coordinating all these activities. So it is an acute care hospital, the trauma center, so we have to take care in the emergency department, which is the acute care, but also because it's a level 1 trauma center, we have to provide definitive care also, along with a bit of rehabilitation. So structurally, we have divided acute care, which means the trauma ED, which includes the trauma resuscitation unit or the red area, which also includes the bedside investigations, you know, like imaging, which is there in the ED itself. All the emergent imaging is done in the ED itself by clinicians. That's something very, very important. And also the nurses, as Dr. Sanjeev said. Then we have our own interventional radiologies in the ED. Then we have definitive care. For definitive care, we have got ICUs, neuro ICU, trauma, general ICUs, then we have wards, and these are taken care of by the individual admitting departments. At the same time, we also have an active physiotherapy or a rehabilitation unit, which takes care of the immediate in-hospital needs of all the patients within the, till the time they are discharged. This is our emergency department. These are a few tenets which we want to propagate, that emergency is not only patient caring area, but emergency needs to include the other areas for patients, relatives. For example, there should be a separate in and out ambulance bay. There should be a entrance area. There should be a triage area. And I'll show you through photographs our ED department as such. Very important is again a waiting, calm waiting area for the patient's relatives, because when they arrive, they are in tension and they need to be coordinated. So our trauma nurse coordinators would coordinate the activities not only with the patient's relatives but inside the hospital also. So that's a sort of entrance for the ambulance bay. Once you enter the hospital, you reach the triage area, and our patients are triaged as red, yellow and green. This again is done by a trained nurse, which is a triage nurse there, along with a junior resident doctor if available. But most of the triages are done by our triage nurses. Once they are triaged as red, yellow or green, they would actually go to the red, yellow and green areas, and principally red areas, compromised ABCs or major injuries, stable ABCDs go to the yellow area, and the walking wounded generally would go to the green area, and everything is divided accordingly. That's our red area, and we follow certain protocols, and somebody has to monitor protocols, and I'll tell you how our nurses would actually monitor these protocols by collecting data. And as Akshay said, it's all data driven, you know, and time is very, very important in trauma, and therefore timeliness of data collection and time-stamped data collection is again very important, which I'll come to in the registry part of it, our session also. That's a yellow and green areas. That's a separate mass casualty reception area. It is very important to have some area which is regularly not patient caring area as mass casualty reception area, so that if your red area or yellow area is flooded, the green area can be converted, can be made here in these areas. So our process of care begins with a triage, and then in the trauma red area, and thereafter the patient, after initial imaging, if he requires an OR, goes directly to OR, or if he requires ICU care, goes to the ICU, or if he is stable, goes to the ward. There is also imaging going on in the ward areas, and there is a constant transfer of patients between, say, the ED, the OR, the ICU and the wards. They can shift between till the time probably if they are discharged or they unfortunately die. As I said, we have imaging. So there's a lot happening. You know, we've got theaters. So all this activity needs a lot of coordination. And that's what we come to. So we've got critical care units. We require 24/7 blood. So there's a blood bank. Somebody needs to inform the blood bank also, be ready for the blood, or give sort of a massive transfusion protocol, send the blood immediately. So all these activities need to be coordinated for finally giving quality care. So we developed very early in the trauma center few nursing paradigms, empowering the nurses, and one of the most important of them was the trauma nurse coordinator system. And this was the first sort of trauma nurse coordination system in the country, which we began in the February of 2009. And obviously, as everybody said, that we got our inspiration from the course which we did in Israel, in Haifa, Israel, and there we saw that the nurses managed and coordinated a lot of quality activities in that center. And believe it or not, when we made a group of 20 people, they were predominantly doctors, and we were told that we will not take only doctors for this course. You need to bring in nurses. So we had to take at least 8 to 9 nurses along with that in a group of 20. So the team concept was very clear in Israeli minds, and thereafter we did this whole 14-day, 15-day course in which we were taught not only about mass casualties, but how disaster preparation can improve a single patient care in your ED. And most of the tenets of quality improvement and other things, infrastructurally, what we have done in our trauma center is inspired by them. So a trauma nurse coordinator basically has a wide scope of work in a trauma center. So basically the trauma nurse coordinator is a pivot around which most of the clinical care, quality care, research, data collection happens within that center. So they do a lot as a clinical nurse, in the sense that monitoring of protocols. They do a lot of administration and education. They're a part of a lot of our teaching programs, and some of you, if you have come to AIMS, you must have seen that our nurses would equally, take part or participate in education programs. And thereafter, they also look after community care, sort of injury prevention activities. So who can be a nurse coordinator? Any registered nurse who is skillful and is interested in trauma care or acute care. Now, the roles and responsibilities include a lot of coordination with the trauma victims, if they are conscious, or their relatives, what is their problem, and then transferring this information to the doctors. Similarly, one patient of trauma is actually seen by multiple teams. So there's a ED team, there's clinical teams like orthopods or neurosurgeons, or polytrauma patients which are seen by multiple specialties. So a lot of coordination needs to be done between these specialties also, whether the consultations are happening or not, whether it is in time or not, who is seeing the patient, how early he's being seen by, say, a neurosurgeon. All this has to be reported and jotted down. So they have this role also. So they would assess and follow up the patients within. So they would not only be a part of the ED assessment and quality assurance, they would also, after their duty is over, go to the wards and collect relevant data regarding the patient, so that we can improve quality in the wards also. So that's our administrative structure. The chief of the JPNATC is overall in charge of the trauma nurse coordinator system. Then there's a faculty in charge, under which a senior trauma nurse coordinator actually sees the whole department or unit of trauma nurse coordinators. Right now we have about 12 to 15 trauma nurse coordinators, because ours is a very high volume center. You can reduce the numbers in your emergency if your numbers of emergency patients are less. Then we have a dedicated TNC data manager who is looking at the data which is being filled by the other TNCs, so that the data gaps do not occur. And finally, there are trauma nurse coordinators. So within clinical practices, the trauma nurse coordinators are nothing but patient's advocate. As I said, they coordinate a lot of activities. They do their duties in the emergency department, and then finally follow them up in the wards till the time the patient is actually discharged. So they facilitate the interdepartmental consultations within the hospital also, not only in the ED but also in the hospital. Then there are a lot of consultations. So they are the pivot in the ED. So they are collecting a little bit of data from the pre-hospital care also. Whether or not the patient actually received pre-hospital care, when he was exactly injured, all this data is very, very important for maintaining a proper trauma quality improvement database or trauma registry. Then they also consult with the discharge planners. A lot of patients are unknown, unattended, and therefore a lot of our social workers would be involved, and they would liaise, the TNCs would liaise with the social workers also. And finally, if they require some rehabilitation, they would call the patients back to the rehab or amputation clinics where the patients arrive. So basically, they tend to develop a culture of we rather than me. Because all of us, academicians or clinicians, live in silos, orthopedic departments living in their own silo, neurosurgery, trauma surgery, and therefore they connect all of us as a team in the trauma center. As I said, they do a lot of educational activities also. They have been coordinators for various courses like ATLS when we used to have that in the trauma center, or the ATCN, pre-hospital courses, emergency nursing courses. They would be the coordinator for such courses also. Then, as I said, they have a pivotal role in collection of time-stamped data of all the patients coming to the ED. So they are the resources by which we collect our in-hospital registry data or TQI data. And finally, they would be helpful in implementation of protocols. They are empowered so much that they can question the consultant, they can question the residents working there as to whether or not the protocol is being followed. And they would report it to their faculty in charge, and thereafter, in the TQI meetings, these cases would be discussed and some sort of a loop closure is done. So that's our incident reporting cycle. A trauma nurse coordinator reports an incident, the faculty in charge then takes cognizance of it, then he sits in the quality improvement committee, some sort of a development of policies and protocols if it is needed, or remediation if it is needed is thought about in that meeting, and finally closure of loop is done. So that's a very, very pivotal and important role to improve quality. Then they're involved in community care, injury prevention activities, and also in disaster management. So whenever the hospital is faced with a disaster or mass casualties, the nurse coordinators would coordinate with the pre-hospitals, they would coordinate within the hospital for all these patients, triage them, whether or not the triage is happening properly or not. So basically they have a very pivotal role. Their standards are self-regulated. We have our surveillance meetings basically with the faculty in charge holds regular monthly meetings with them. The data manager presents the data, the timestamp data in those meetings, and finally, they are also a part of the M&M review meetings. There are challenges faced by them. A lot of residents or the consultants would not listen to them, or they would have constant struggle in informing them because they are treated as spies who are taking, cognizance of whatever is happening bad, and they would report it to the chief, and therefore at times they're not supported that well by the clinical departments. Then obviously there are violence incidents in the emergency to which they are exposed, and then a lot of patient load is there, so they bear the brunt of a lot of patient relatives who are there's a hue and cry. So there are challenges faced by them, but nonetheless we all support them at the administrative level, and therefore they are a really motivated lot to improve patient care. And I think they actually work on this dictum that next to creating life, the finest thing a man can do is save life. Thank you so much.
Thank you, Dr. Amit. Any questions? Okay. Thank you. May I call upon Dr. Patanjali Devnayak to talk on innovation, the coming revolution in medicine. Are we prepared?
Caller mic. Caller mic. And my slides. Respected chairs, ladies and gentlemen, and my friends, my topic is challenging by itself. It talks about the coming revolution in medicine, and that is where I'm going to speak about. By the time the slides come and the mic comes, it's going to be provocative, it's going to be disturbing in the sense because I'm going to ask difficult questions from my own self and from you all. That we had some of the points coming up, and especially from my colleague here, that how do we manage 180 patients a day, or as Amit brought about, how do we manage some of the challenges. And questions have been raised since yesterday, and that is what I'm going to focus upon. I'll move upon on this area. Can I have the... As you see the names there on the first line itself, I went home yesterday, I missed some of the last sessions to rework on my presentation because the points I heard from people, from Dr. Venkat is here, the questions he raised about Srinivas from the Tata Trust and others. In the morning I had discussions with Dr. Sriram, Dr. Brad, who is not here at the moment, and one young man, Kiran, who stimulated my discussion, and that's where I brought about. It's very clear the 3 points which I want to bring about here. What is this presentation about? This is to demystify, create awareness of the technologies so we can make it easy. Quality control, Akshay. A lot can be done by technology, utilizing that, and your job, and what you're talking about in there, and Vishnath is here. I want to disturb the existing ecosystem as my friend brought about. Why do we see 180 patients a day, sir? If there is no time limit given, you can set your own. Has somebody told you that you have to finish off the OPD and then only go? So that's the question we got to ourselves, that we have allowed ourselves to meet with these circumstances, and now we are in a quagmire, we are unable to change them. Because, and we should have asked for standards. There are no standards, then you set your own standard. That I will see a patient howsoever time he requires. That's a life in question. Not that I have to finish off the OPD as we say. So the ecosystem is the chair, and that is where I want to cause the disturbance amongst all of us, including me, that's the change is going to come up. And we work in silos. I'm a cardiologist, I'm an ophthalmologist, I'm an anesthetist, etc. the areas. We want to develop increasing and deep partnerships. I want to again thank Sriram, you and your colleagues for the partnership exhibited here. Is one of the finest examples of the partnerships with philanthropy, PPE, government, and the doctors themselves. So we want to have partnerships in these areas with IITs, startups. That's where the young man Kiran stimulated me. Incubators, hubs, individual innovators, global players, etc. And this presentation recommends that we adopt all these technologies as a bundle, not pick and choose, Vishwa. That's where the problem is. Oh, we will do AI, but we won't do quantum. Or we won't do Internet of Things. So those are the issues which are troubling us, because we pick and choose, not realizing that I am not competent to say whether I should use this or not. The technology is offering me something, I am not taking it. There's a whole issue coming up, and that's what I want to say. Recommendation is that as a bundle, this area. And as I said, I'm not expert on anything. I'll move rapidly now because most of the slides are pictorial. But in the meantime, I'll keep disturbing you, young ladies, Sonali. That is what is going to happen, because you are all the future. This is going to come out. There have been developments in medicine from time immemorial, and we have been on the shoulders of others. These examples, so many of them, how other branches contributed to medicine, Vishwakarma and Dr. Krishna. This is what has happened. We all know this. So, just read this. I'm not going to insult my audience by reading every line, but the idea is that this remains in store. Anybody who wants to use my slides, most welcome. These are some examples which are just picked at random. How medicine has enriched itself from other branches, whether it's chemistry, physics, molecular biology, biotechnology, plastics, whatever you read about is there coming up. Just a small representative list. It's not exhaustive at all in any ways. The press has started covering all the areas, it's coming up all the time. And these are just two examples from economic times. So this is not from any medical journal. This is not from scientific journal. This is from economic times. Why is Pedenji, economic times, talking about these AI and other areas? And this talking about here small, how a young team built a surgical robo. The whole paper is given to these areas. They have reason behind. They have seen it better than us. And that's the problem I bring up. Are we ready to utilize this? If you are not ready, we'll be left behind. Are we ready to be left behind is the question your patient will ask you, sir. We are not. So this is the question I ask. Is the medicine/emergency medicine of today, Vishwa, even in Kerala, are we utilizing the available technologies well? How well? Second, what changes according to you and all of you are sitting here are required in the ecosystem, the policies, training of health personnel, and in other areas to harness and leverage these technologies? What technologies? A very small list given here. I'll touch upon some of them. These are available right away. And some very few, like say quantum computing, are on the horizon, say another few years. But most of them, smartphones, what you have in your phone, is one of the biggest and the best and the efficient technology, which we are not using even 5% of what it offers us. We're using it, but we are not using it that well enough. So many technologies here, whether AR, WR, just again a list of some of the things I'll be speaking on. Thus there, alarms and alerts for the emergency areas, we can talk about it. Is there how it links us up for the falls, and you'll find each technology when linked to another one becomes a force multiplier. That's where the mobile phone helps us the most, especially with the new apps coming up. Hundreds of them. They become a force multiplier and changes it. So one small box can really bring about a revolution. Simple as that. So you have a phone and you have this Bluetooth stethoscope. The mother can put on the child's thing, and a doctor listening, Ashil can listen from Delhi and tell what is happening in a Kerala village, just because we have these small things. Telemedicine, I start with this because these are some of the known ones. But again, the question I ask Sri Ram is, are we using telemedicine to the hilt? Can we exploit it further? Can we do it better? Are we doing this area? That is the question coming up. It's not, my idea is not to enumerate the technologies and just go away and have a clap from you all. Oh, yeah, you got. This is just a collection of ideas. None of them are mine. Mine is the question I ask us to provoke to every one of us and disturb. Why are we not using them when they're available and they're being used by others? What stops us? It's the mindset again, Vishwa. It's okay. Or not being aware of them. Or third, not knowing where to go. I may not know, but I can go somewhere. I can go to the library. I can go to a technologist, do this. So that's the point coming up here. So here. Health sensors and telecom. We are all having smart watches. We are all having now something which you do on a tablet. You can have a discussion. You can have a consultation. This is happening in the COVID time. This is how things move. Excellent way. I think this is one technology which has come home now to stay with us, is teleconsultation, looking at people, giving them advice, counseling. Even it helps in the emergency time a lot. If somebody has fallen or somebody has chest pain, if you see on the video, you can. I cannot go into the details of everyone, but I'll just touch upon how in the emergency medicine area these technologies are going to help us. Biotechnology is there, vaccines, production of artificial organs like cornea, liver, skin burns. Dr. Sujata, I went home and added this, especially your name after the long discussion we had. You were very worried what the burns, there's hardly anything. Yes, but are we actually talking to people who can help you? Can we have artificial? We know we can have artificial skin. We can have skin from the same cells from the same person. So why are we not using it in Safdarjung? So my idea is to disturb you. You are a close friend, you are like a sister. But if I don't disturb your mind, we won't improve because you are passionate about it. But you are lost. क्या करूँ मैं? कुछ करने के लिए है. 5G. Yes, you're reading correct. It's about the telephony 5G and 6G I'm talking about. It is going to revolutionize because of the linkages caused. This is, Sri Ramji, this is supposed to be going to open the flood doors for the changes in medicine. And we are not even using 5G even in the phone still now. Forget about using for emergency medicine. Because we are not aware what it can do. It's not our problem. So my job is to bring awareness, but at the same time keep nudging us all over. Let's use it. Let's do something and find out ways of using them here. So we have 5G all around. Here it is coming up how 5G will make healthcare affordable and accessible. And that's Times of India talking about, not BNJ. And we read it, but we forget it. So that's where 5G coming up. Quantum computing. As I said, so this is again supposed to be, if you ask Bill Gates and other, he says this is one of the technologies which is going to bet upon in the next few years. It's on the horizon, it's not available very much, but it's what's used in climate forecasting. That's what you use quantum computing. But if you crunch data, health data with that, we have a problem. This is going to help. 10,000 years work, which the mainframe computer would do, is done in 3 minutes, 30 seconds here by quantum computing. 10,000 years equivalent to 3 minutes. That is the power quantum computing offers us. It's available in India. but it may well be. So my friend here from the health ministry, Krishan ji, आपको कहूँगा मैं, यार 100 crore लगा के बनवा दीजिए quantum computing एक. Let every state send the data, you analyze it, send it back. It can be done. The idea is somebody has to start it, and for such things, the nodal agencies of yours comes either Government of India or state governments. AR, VR, brain-computer interfaces, just moving it. One of the persons I know, his son was in this competition. He was so happy seeing the slide in the next time. Sir, this is around the next, this is the 4th or the 5th presentation I'm making, and I always change it depending on the group which I'm addressing. I did to the pediatricians, I did it in Kolkata to the geriatric experts, I did to the Lady Harding Medical College students, which is where I started what. I'm going to show you 2 slides what they talked about. AI. Crowded slide, deliberately I took it, I could have written it myself in a very nice way, but this is what shows AI is in every part of healthcare. From diagnosis to data, to treatment, to management, to research, to triage. So I'll quickly take you through some of the slides here. In public health, screening for NCDs, cancers, diabetic retinopathy. See, please remember, we are physicians and medical people first and emergency medicine people later on. You play many roles. So we are also for the NCDs and the areas coming up. Consultation with the doctors. Now that's where, sir, the answer to your question. Should every patient start consultation with you? Or can we use AI to see that some of the things are managed there, and those who require a real time, an expert like you only should come to you. So those are the answers. That's the reason I'm pointing it to you again and again, because you asked a question which has troubled me through the life. I used to sit in a cabin as big as this sofa, I and my wife, both ophthalmologists, in one cabin. And 120 to 150 patients in the June-July month of Delhi would be all around us. So I faced this, and I used to curse myself, what is the answer? I didn't have the answers. I still don't have. So that is why I empathize with you, because I myself gone through. But some of the answers have started appearing now. This is the way, can we shift tasks without reducing quality, what my friend is talking about here. Mammograms. 1 out of 3 mammogram reading is false. So women are either made to go through biopsies or mastectomies. Are we fair, Praveenji, to our sisters, our mothers, our daughters? Because mammogram is one of the dependable ones. So if you use AI and you can read the paper, what it says, what hugely correct answers you get if you use AI, if you machine learning, if you train the microscope once to detect these cells, pathological cells, it does a better job than an average or an above average pathologist. What a beautiful thing, it's already available with us. AI glasses, one of the favorites which we have for low vision or no vision here, which we use, multiple technologies, ultrasound, geostationary positioning, so many other things are joined together in one area. That's the reason I give the website linkages also, that anybody who wants to learn more can do that. Precision medicine. I ask a question to many of my colleagues. Why should we be giving ampicillin 500 mg or 650 mg amoxicillin or whatever the percentage to every patient? Because it's convenient for the pharmaceuticals to produce it. And we doctors follow all through that. I'm sure, Manas, your requirement for an antibiotic would be different than, say, Vishwanath's. Or ladies, there are different metabolisms. We know that with the sex changes play a role there, so that is what is happening. So they say that, but we don't have that. I'm going to need a little bit more time. Simulations coming up, triage in emergencies. AI can help us there. Internet of Things is the next revolution coming up. It's already there, not coming up. We are not utilizing it, but it's being utilized in many of the countries here. It's all connecting the vehicles, emergency responders can, reach up there. This is where the emergency responder use the IoT, the Internet of Things quite a lot. Access patient records, transmit patient's vital, the cell. That is what you now you're doing it through a phone. But if you do it through an IoT, you have a live feed coming in. Hospital examples, how we do that is a blue alert, code blue, how do you go about it is coming up. Personal emergency responses, somebody falls, either the machine sends a message or the person sends a message through IoT, coming up here. So On the left side, you find there are three things which are combined together are going to revolutionize emergency medicine. That is AI, IoT, and blockchain. And what is blockchain? That's the reason I use this slide on the right-hand side. I try to give some other points. If you remember a Bitcoin, I cannot go in the details of blockchain, but these three things together, Vishwa, we can have a discussion later on how Kerala model can utilize technologies as a next step to really change the whole scenario. Drones, we all know, Government of India has used. This slide below is from Nepal, how they have also used. I wanted to deliberately add a slide from other countries to show that smaller countries than India are doing it because they found it valuable, they found it useful, they thought about it. That's what is happening. This is from India itself, using vaccine for drones for transporting vaccines. This is in emergencies, how drones are used. In many ways, this shows the slide from a fire, but it can be used in any other emergency as the responders. 3D printing inside the body. This I collected from one of the WhatsApp in shots just a few days ago, and I was myself surprised. It's not only 3D printing with the 3D printer outside, which is now almost, a printer is much smaller now, it used to be bigger, but inside the body we can do this. Imagine how you can revolutionize, you can manage patients right on the spot at the disaster by having 3Ds. Robos in healthcare, robotics, and there is a robo bringing water or medicines, so you don't need a nurse to send to infectious disease, people say even in COVID and other areas, when we have robots. So that is task shifting from the doctor to the nurse, from the nurse to the robo, so that is how we utilize. We must utilize technology to see our healthcare personnel are free to do other important things. That's coming up. Robotics, wearable robotics, and the next one coming up is robo-pharmacy. Just into the idea, that is where Manas I talked about. The robo will decide what amount of medicine do you require and how much, and it dispenses it. You don't need pharmacists. Imagine a large number of pharmacists are free to do something else rather than giving medicine and compounding there. And this is the Spider-Man movie which I used, the exoskeletons. Nanotechnology is the next one which we are using too little, too late, and it can do. Can perform surgery at the cellular level, removing individual disease cell rather than giving a big scar to removing the whole kidney. If you have an adrenal cell carcinoma coming up, just imagine what we can do. And a nano is a 1/1000th of a meter, that is 1 by 9 zeros, followed by 9 zeros. Infections, Manas again, we don't need antibiotics now. The nano robots go and fight the infected or the pathogens coming up the area, clearing up the arteries. Scattered innovations. I added this slide yesterday after listening to Kiran, and one of the things coming up, startup has made robots from, this is from Kerala itself, here it is. I may be the same young man. The school kids at IIT camp gave life-saving ideas and how to make oxygen from water when we did not have oxygen. These are available by startups, by young kids of India who have done this, and they are now in the mainstream. They just need to be brought up at a scale. That's what we're going to talk about. And this is possibly one of the second last slides. Don't forget simple things available to us. This is me, sir, in Konkan on the motorcycle, and Shaukat Ali, the nurse from AIMS JP Apex Trauma Center as a pillion, just to demonstrate that this is what is being utilized. We have a motorcycle ambulance with a defibrillator. Many of you have gone to Konkan, have seen this. This could be utilized much better than what is being done at the moment. Thank you very much. So this is the last slide. Essentially says the same thing with the first slide, but in a different way. It motivates us first to say, change is imminent, it is happening. Are we going to capture it and flow with it? Or have we decided to stay back on the shore? The choice is ours. The slide says only that. There are 8-10 points, that doesn't matter. But this is the essence in my mind when I developed this slide. And I'm sure we are not ready to going to stay back, Vishwa. In no way can you keep us away. So the idea is, can we now find out ways with the government, maybe with the philanthropy, maybe with the startups, to see how we mainstream all this technology, if not all at one time, at least bundle 4 or 5 of them and bring them here and see through it that emergency medicine improves, and medicine improves as a whole, so we can save patients and not have the burden the way my friend talked about and reminded me of my own days. Thank you very much. Thank you. I apologize for having it taken a minute extra.
Thank you, sir. Please stay on there. Any questions?
Thank you, sir. I represent my college, Safdarjung Hospital, and during COVID time, whatever you had shown us, we had made a robot. Our colleague has made a robot, and we had implemented. But problem is that, what we have made, how can we bring it to the other fraternities or other institute who will take up this project further? That's my question, sir. Because I have a project, we have built a project like communicating with each other colleagues during our sessions.
I got your point. If you allow me, I apologize for interjecting the ideas. I've already taken extra time and we are late. We must respect my forthcoming speakers also. Excellent question. 3-4 small bits, it's going to take an answer. First thing is build consensus around it. Exhibit, show, let the robo work. Second is get those people who have benefited by it, that is your nurses, to speak about it, to talk. Yes, ये अच्छा काम करता है, हमारे को time बचा है इसे देने में, कोई accident नहीं हुआ. Third, get the patient's feedback. They say we have no problem, we are not. Was somebody scared with the robo machine? Was the child scared, or they wanted to play with it? So got it, make it playful. Why are the robots made humanoid? Because people are less of a thing which is in their own body fashion rather than a static one. So bring up those. Write up, make a program, do a small write-up in a newspaper with a photograph, get your friends to do that, talk about it. It will start happening. Get people from other things. You have friends in every department. What stops you? Why do you ask this question to me? You have the answers.
Okay, thank you, sir. May I call Dr. Ashil, Dr. Akshay, and Dr. Amit, please come out to the stage.
I request the chairpersons, Dr. Suma TK and Dr. Tajan PJ, to hand over the memento to our chairpersons, to our speakers. Dr. Mohammed Ashil. Dr. Akshay Kumar. Dr. Amit Gupta. And Dr. Patanjali Dev Nair. Now I request Dr. Vishwanathan KV, HOD of Emergency Medicine, Government College Trivandrum, to hand over the memento to our chairpersons, Dr. Suma TK and Dr. Tajan PJ.
We thank myself and Dr. Suma Madam. Thank the organizers for allowing us to chair this session.
Thank you, sir and ma'am. Now we'll be starting off with the next session for the day. The next session is on building a robust integrated emergency care. And the chairpersons for this session will be Brigadier Dr. Venkatanarayan, Dr. Ajay Kumar, and Dr. Sanjeev Boy. I invite all of the chairpersons onto the dais. We invite the chairpersons, Brigadier Dr. Venkatanarayan, Dr. Ajay Kumar.
Did this one? The page down I can use, no? Okay, okay.
Yeah, next.
Okay. Good morning, everyone, all the experts and the future experts. I'm really happy to be part of this KEMS 2023, and I really thank the organizers for inviting us also to be the participant here and also the faculty. And just about, I'm going to talk just about only the evolution of history, actually, emergency medicine, and a few lines about our Tamil Nadu initiative, how the emergency department is developed. And our expert, state expert, Professor Dr. Marudurai will take over regarding from the transformation from casualty to emergency medicine department. There is no future for who forgets history. See, this is actually a 24 into 7 into 365 days. We as an emergency medicine team, it is not only the doctors, all the multidisciplinary approach like paramedics also involved. So, coming to this, it's a relatively young medical specialty. Here comes the safety net of the safety net for the patients who are unable to get care. Actually, it is a specialty of undifferentiated resuscitation and care, and all categories of the patients who need emergency acute illness patients are catered. And we are responsible in that emergency department for the immediate recognition and evaluation and care and stabilization. So history, coming to the history as a word, this all experts know already, just recalling the history. The actual practice of this care is as old as medicine itself, but as a specialty, it's a very, very young. Especially in India, the oldest medical, script existing in probably the Edwin Smith Papyrus in circa 700 BC, where it was described as the mandible dislocation, how to put this in one of the circa. Next is coming to this Chinese dynasty, they tried all these procedures like osteomyelitis. Because of this, they tried the dead bone removal concept. Then Julius Caesar, during this circa 100 to 44 BC, introduced the idea of this doctors in the battlefield. That is, first army medical officers were put into use to give good care to those who are really injured during the battlefield wartime. So this evolution of this medicine is a first stage at advanced, actually the dressing stations. So coming next is the first organized use of this ambulances came during this wartime, especially the father of emergency medicine. That is French chief military surgeon Baron Dominic Jean Larrey introduced the flying ambulances during this Napoleon invasion of Italy. And 1853, this Britain entered into the Crimean War. And November 1854, the lady with the lamp, because of the lady with the lamp, the mortality is reduced from 1:3 to 1:40. So much care was given in the battlefield itself. So this, in 1935, Professor Martin Krishna and Murray recommended this casualty should not be brought to the physician. The physician should be brought into the casualty site. That is the concept in 1935. This laid the foundation of emergency medical service system in Europe. So in UK, 1952, Maurice Ellis, the first casualty consultant, but he became, in 1967, became the president for the Casualty Surgeons Association. So then in US, this association was headed by Dr. James Dewitt Willis, and before 1970, all the emergency were provided by this staffs, family physicians, general surgeons, interns, but always they need training in the emergency care. So the residency program began in 1970 at the University of Cincinnati. First department of emergency medicine was started in 1971 at the University of Southern California. So olden days, they should have that is a special emergency entrance with a bell. Only on pressing the bell, when the patient is returned, only the staff nurse will open and allow the patient to be inside. That concept was developed. And John Winston, this is the father, mainly concentrated on medical emergencies. And because of the turnover of the patients to the emergency, acute illness is too high, a new kind of doctor is required during that time. This is the old nursing stations, just pictures from the net I could collect. Do we need emergency medicine department? So coming to this, because of the economic and scientific societal changes past 30 to 40 years been underlying the catalyst for the evolution of this modern day emergency medicine. It also realized standard of care, that is special group of patients with acute illness actually or injury. They are placed, they came for the necessary treatment or management in the emergency department. What does in the hands, into whose hands? Dedicated doctors who will make, not only dedicated doctors, all the paramedics, including staff nurses, will make this subject the permanent interest with the responsibility. And all these were instrumental in establishment of the modern day emergency medicine department. So the basic requirements is interested physicians, support from other specialties, and government support, most important, and good healthcare infrastructure. Infrastructure aspect, you have a good healthcare facilities and training program for the healthcare providers, specialist referral support, and transport and communication. As we all discussed regarding the transport system and communication almost for past 2 days, then mature emergency department includes this transport, trauma care, national database, quality assurance, peer review, subspecialty training, evidence-based medicine, and disaster medicine. Previously, the patients were routinely transferred to the nearest hospital, but it should be nowadays, it is transferred to the appropriate closest hospital actually. That because of the proper communication development. So emergency physicians actually participated not only in this internal aspects, international relief organizations also like Red Cross and Doctors Without Borders dealing with disasters and crises. And this also a part of your curriculum actually, disaster preparedness and response, and part and parcel of this curriculum of your emergency medicine training. In 1990, this BAM in 2004 and 1993 FAM, and both merged in 2005, like that conducted membership and fellowship program. And this I want to share because it's a symposium of emergency care was done by the American Council, that is College of Emergency Medicine in November 18 to 21 in 1969. Just think of it, in 1969, they have conducted a symposium of emergency care. Now, at least we are happy this, after for so many years, we could continue this system in our setup. This is a olden day casualty in the above picture showing, and now this is improvement in this system. And the new emergency medicine men have arrived to cater the really acutely illness patients coming to our department, the public or private setup. Coming to the Indian scenario, especially in Tamil Nadu, this is the 7th largest, most populous state, and need in both urban and rural because of the complete with the dense population hospital, regardless of this patient's paying capacity or medical legal status at the time of emergency. So, failure is to be the violation of this patient's right to life, which is guaranteed by our Constitution of India. So closest to this, like EMTALA or COBRA of USA, they have enacted laws, and because of that, we are able to do this service properly. And time up. So we are not able to match up this emergency department because olden days, the triage is not done properly, not the specialists are posted in the emergency department, actually in the casualty. Even in rural setup, the obstetric care was not taken care. But nowadays, in the different aspect, the defense aspect of our India itself, they have taken care well. All people were trained, even paramedics were trained in taking care of this emergency aspects in military. On this thing, first privatized emergency department, as already described yesterday, it is Sundara Medical Foundation 1990 along with the Long Island Jewish Hospital in USA, they have incorporated that. First privatized that emergency department on it, Chennai. And as per our MCA rules like 2009, this medical council recognized the emergency department as a separate specialty. These are the interested societies, you know already. Coming to this, 2009, it is recognized because it is very relevant to the largest population. Our country is the largest population in the world with the highest burden of emergency. So, huge daily burden of patients is the limited availability of this trained emergency doctors or physicians, and also the trained persons for triage is not available in the olden days. So need for this hospital staff to be educated to facilitate the patient flow in a seamless manner. And major milestone in the evolution is this. Today, our emergency departments are staffed by the dynamic emergency physicians, and not only physicians, all the cadres, I still insist, all the cadres are trained properly, and emergency department is a face, it is a lifeline of our hospital generally. So it thrives in the atmosphere. That's the most important thing is, it thrives in the atmosphere of high drama, quick reactions, efficient saving of the lives and limbs. Occasionally, we are as a witness to great tragedy and intense grief also. So this coming to our Tamil Nadu, with the help of our former mission director, Dr. Daras Ahmed, and former project director, Dr. Nagrajan, and present MD Shilpa ma'am and project director, Dr. Umma, and our principal secretary, Dr. Sandil Kumar, and under the leadership of our Honorable CM and HM, Health Minister, this 6 pillars of THOI were created, from the communicable disease to the catering to the non-communicable disease, not only to trauma. So they designed, first concept is 6 pillars, like first pillar stroke, second STEMI, third is the trauma, fourth is the burns, and fifth is the poison, toxicology, and sixth is the pediatric emergencies. So here time norms are fixed as already I have described. Each step, the protocols are followed properly as per the guidelines, and the common procedures of the protocols are followed, and checklist even for the healthcare workers for each stage, and all the standard registers or whatever documentation is standardized properly. Then this, as per this THOI, we have a pre-arrival intimation through this 108, and nowadays this is an ongoing project. We have a trauma registry also that will be described by Professor Marudhu sir properly. And next is trauma reception, resuscitation bay, time start management, point of care lab, and linkages with multidisciplinary units, multi-critical care unit. Actually, it's a triage is a nurse-driven model. As he said, nursing is the most important thing. Actually, nurses, nursing coordinators, next, they are the triage center in the triage area, actually. Nursing team and training, continuous training is going on. We have a skill labs. It is a continuous training program is going on for all the cadres of the emergency department. And most important thing is a rehabilitation stage from the day of admission. So THOI concept is the attitude, it is the organizational concept. It is not an infrastructural concept. This here, being calm amidst chaos, this is a tips how to be an expert emergency care physician or emergency health care service provider. Prioritize, focus, make time, make a list and check it twice. Practice makes perfect. Following protocols always protects. So this emergency team, here they will be received, all the emergency patients, those who need the care, they will receive passionate and state-of-art care. No one is neglected, no one is turned away. Emergency physicians are jack of all trades, master of none. That is the time. Here plays the time. Its medicine is more art than its science, actually. So ours is the THOI symbol. We saving lives is our mission. Learn, adapt, apply, outly, and save skills. That is the most important. Still insist, continuous training, review of all the things happening. Every month we have a THOI death audit, trauma death audit, and poisoning audit. Everything is going on. So, and also continuous training program is going on. So save skills, saves lives. And our course started. Objective of this MD emergency medicine, knowledge, attitude, and skills. As said, knowledge is important, and application of the knowledge properly with a good attitude and efficiently, effectively, and to all in an equitable manner to all the patients coming to our emergency department. The skills is most important. Apply the skill as per the assessment is important. And these students are trained in medical legal and medical bioethics research methodology as per our Tamil Nadu, Dr. MGR Medical University curriculum and syllabi. And milestone in this development of our emergency medicine, THOI launched in the process put in place in 21/06/2017, and establishment of emergency department in 25 medical college hospitals in Tamil Nadu started in 22/10/2020 with the they have created the post like emergency department professors in 25 medical colleges, and associate professor and assistant professor of 27. Additional one post is for the attached institution like Institute of Child Health and GRH, Royapeta Hospital, and ED secretary post also created in the 25 medical college hospitals for the smooth flow of these patients and smooth conduct of your emergency medicine training also. And as per the NMC Gazette notification, 120, we applied for 120 PG seats in 23 medical college hospitals, but 84 were allotted. And first CME program for emergency medicine, MD medicine post, conducted in December 7, 2022, along under the leadership of Honorable HM and Principal Secretary, and strengthening of regional training centers, equipment, not only equipment, like human resources and training calendar, everything is prepared for the whole the year actually, including all the paramedics. We are continuously doing this training program for all. We have created a APEX, and that is hub and spoke model. APEX center is our Rajiv Gandhi Government General Hospital, Madras Medical College. So training program is continuously going on in regional centers. So all, not only from medical colleges, from district headquarters and taluk hospitals, all the doctors are coming, or not doctors, staff nurses and paramedics are getting trained in these centers. So we are trying to fulfill the need, the demand of the public, that is emergency societal health needs. And I'll hand over to Professor Mardhu sir regarding this, how the casualty evolved and the transform from casualty to the emergency medicine department in emergency Tamil Nadu. Thank you.
Madam, we'll take questions in there. I request you to occupy the chair.
No problem.
Yeah, Madam, after the second talk, then you, because you will have to leave early. So.
Now we invite Dr. Professor S. Marudhurai to talk on transformation from casualty to emergency medicine department.
Respected chairpersons, my previous speaker and our team leader, Madam DME, erudite scholars, team leaders, and my dear students, I bring good wishes from Government of Tamil Nadu to God's own country. And I thank Professor Vishwanathan for giving me this platform. And I utilize this platform to thank Niti Aayog, our chairperson, who have been instrumental in creating Tamil Nadu Accident and Emergency Care Initiative in Tamil Nadu. I thank WHO, I thank Government of India. And as the thankfulness continues, it's a strange, not a strange, a blessed correlation that Innatha Divasam Sakhavu EMS Avara Charama Varshika Dinam. EMS resides in KEMS, and that is where Kerala has made the difference, and I wish Team Kerala a very pleasant and a very successful journey in establishing emergency services, which is bound to happen. The 6 pillars, as Madam has already outlined the NCD burden on the society, and in the face of an emergency, when a patient reaches the hospital, what is the state of preparedness in the hospital to meet not just the professional duties, but the emotional demands of the society? Next slide. Next slide. Okay. My topic, the casualty to Department of Emergency Medicine. It is a part of the journey from towards emergency care system in Tamil Nadu. Yeah. How this came about, the transformation, this topic was chosen only following the recently respected member Niti Aayog, Professor Dr. V.K. Paul, visited Tamil Nadu to study our system along with our chairperson today. He was in Chennai last month, And when he visited Kilpauk Medical College, of the 6 pillars, regarding burns care, he visited a young child with burns who had undergone allograft skin grafting from the skin bank maintained at Kilpauk Medical College Hospital. And he was all appreciation for Team Plastic Surgery doing this wonderful work at Kilpauk. Later, another pillar, toxicology, the students had organized a wonderful exhibition, because as much as we care about the number of lives lost on the roads, about 50 patients every day in Tamil Nadu, if they are dying due to RTA, equal number 50 patients are dying in Tamil Nadu due to suicides. It is as much a problem, as much like trauma. So students had organized an exhibition, and the faculties had written a toxicology manual, which Professor V.K. Paul released. And on his way, he was just telling, you please contrast casualty and emergency department, and the differences you please give as a document was the assignment given to us by him. And that is the reason for this topic here today. The old casualty, and this is the emergency department today. What was the actual casualty in the previous casualty was the system. It had to be, there was no system as it is. THA is an organizational concept and not just an infrastructural change. The changes are the branding, the central nursing station, making it a nurse-centric model, the triage desk, the bystander movement regulation, which has brought down the number of assaults on doctors in the emergency department, which was happening very frequently in the previous years. It has brought about this change. What were the gaps in the old casualty? All of you know that it was the least priority in any hospital. Nobody wanted to work there. And it was assumed that casualty is everybody's responsibility. Everybody's child ultimately becomes nobody's child. It's after all, only my child is my child. So there was no head to monitor and evaluate. Actually, there was no triage. There were no staff trained in life-saving skills, emergency life skills. There were no standard operating protocols. And there was an absence of academic course in emergency care. And these were the gaps. And when these gaps were identified and tried to be addressed, resulted in THA. And more so, we know 30 to 40% of in-hospital deaths are actually preventable if only intervened on time. Time is life, time is brain, time is myocardium, time is everything. And what is the other dimension of time? I will conclude in my last slide. So the overview of the transformation is, the emergency care system before THA, we have talked, then THA came in, and we created a Commissionerate of Trauma Care. MD NHM is our Commissioner of Trauma Care, and then strengthening of the pre-hospital care system, and then followed by the strengthening of in-hospital care system, training. We released the standard operating protocols, then we commenced the MD Emergency Medicine course. We have created the THA registry, which we call as the trauma registry. It is not just limited to only trauma patients. Even the non-communicable diseases, emergencies are also entered in trauma registry. And we have created a corpus fund for the department to be self-sustaining. So all this has been brought about by the concept of THA. So on 5th March this month, at 2:30 a.m., a lorry driver, 27-year-old male, was driving a lorry, probably his left off, hit against a tiled house, and the wooden piece got into his chest. He was taken to a level 3 hospital, level 3 THA center, Avadi GH, where the patient was resuscitated and referred to Kilpauk Medical College Hospital, which is a level 1 hospital. When the patient reached there, but that hospital does not have cardiothoracic surgeons, so the general surgeon there, what he did was he stabilized the patient, put in an ICD. He gave a pre-arrival intimation to Madras Medical College. And when once the pre-arrival intimation reaches Madras Medical College, the team is ready. At 5:55, the patient reaches the hospital. 6:20, the patient is in the theater. And within 4 hours, this log was removed and the patient had to undergo a lobectomy. And patient was discharged the 13th day. Patient is doing fine. This was possible only because of the coordination between level 3 to level 1 hospital, and where there is no specialist available to the next level hospital, the pre-arrival intimation, the state of readiness, the preparedness in meeting to that emergency, that is what makes the difference. Next slide. This was, of course, this year. What was the scenario 1 year back? It was on 10th March 2022 at a village near Kallakurichi. At 11 p.m. in the night, this patient had sustained a stab injury and he was brought to the hospital there, who resuscitated him and he referred them to Kallakurichi Medical College Hospital, which is a level 2 center, which does not have a cardiothoracic surgeon. They again put in an ICD, but the patient had developed a cardiac arrest. Patient was intubated, blood was given. The patient was taken to the ambulance, shifted to Salem Medical College Hospital at 2:30 a.m. in the morning. The cardiothoracic surgeon team was available, ready. Patient was taken to OT and he underwent. The patient had a tear in the left atrium. The right ventricle bleeding had developed, and that was the reason, which was repaired, and the patient was saved and the patient walked home on the 15th day, and the patient is even doing well today. And this has been possible. And the transit from Kallakurichi to Salem, it takes almost 2 hours. Patient on ventilator, patient on blood, a doctor accompanying the patient from Kallakurichi to Salem in the middle of the night, and the patient walking out, discharged on the 13th day. This is what Tamil Nadu has done. Next slide. It is not just the headquarters ownership to the down level, the next to every level, the support staff, the ED secretary, the assistant professor, ownership at every level. That is what the whole monitoring is all about. Innovations in pre-hospital services is the next step. Tamil Nadu has got 1,353 ambulances. WHO prescription of 1 lakh population, 1 ambulance. We have exceeded that, and we have marked the entire state into grids, a 2 into 2 square kilometer grid. 36,000 grids have been identified, and the accidents of these 36,000 grids, the top 500 have been identified, and the ambulance positioning is what is called dynamic ambulance positioning is done, and efficient patient shifting is coordinated. This is the strengthening of the pre-hospital services. And once the patient is referred, it is a scientific phenomenon, a hospital referral, IFT, inter-facility transfer, is not a cursory referral or shirking of responsibility from one hospital. It is once the patient is referred, the pre-arrival intimation, this is how the receiving hospital registers the pre-arrival intimation, and the state of preparedness is ensured, and this is the effect of trauma registry. The definitive in-hospital emergency services, Madam has briefed creation of the department, the various posts created. These are the 3 hospitals, level 1, level 2, level 3 hospitals. I can say with a sense of pride, in-hospital care at a non-Thai center in Tamil Nadu is not the equivalent to the standard of care in a Thai center. That has been established, and this is what makes the difference when the patient presents to a Thai center in Government of Tamil Nadu. The 3 T's, triage, treat, train. This is the mantra for the success. Emergency department is not just the face of the hospital, it is the soul of the healthcare delivery system. So that much sensitization has to happen, and unless that sensitization happens, it will be just another department. It's the word casualty. We don't have casualty anymore in Tamil Nadu, but as the saying goes, old habits die. And if the patient is a polytrauma patient who requires multidisciplinary care, which department is going to take over the patient? The timeline is within 6 hours the patient should have been taken over by that concerned department, and no longer the old habit of the patient lying in the emergency department or in the casualty, as nobody's baby cannot exist. Within 6 hours, that patient has to be taken over by the concerned specific department, depending upon the severity of the injury. This has been ensured. The training, which is an ongoing program, I can probably say that more than 26,000 of our healthcare workers, including doctors, nurses, have been trained, and it is an ongoing program. It's a 4-tiered training. 25,477 people have been trained. This is a simulation lab in one of our hospitals. And we observe these red letter days, and we also do community outreach activities, organizing awareness rallies, public discourses. So from being a paper-based registry, the transition into an IT-based registry has been ensured through the facility has been created in 6 hospitals, and where a plasma exchange machine is not available, the hemodialysis machine can be used for plasma exchange, and in 16 of our institutions, this is being done today, and so many patients have been saved. The standard operating protocols released. Myocardial infarction, 2019-2020, the percentage of patients who present to a system who are not receiving any kind of thrombolysis or revascularization, which was 30%, has come down to 20% today. Their patients receive thrombolysis at level 3 hospitals. They are referred to level 1 hospitals where there is a cath lab, and within 24 hours, a pharmacoinvasive treatment protocol is ensured, and in institutions, primary PCI is being done. In my own institution, for patients who present with acute MI, STEMI, the door to device time has been 18 minutes. This was the recent, yesterday, team from Telangana had visited Tamil Nadu. They visited a level 3 center in Tirutani GH, and this is the director of medical education who is inspecting the facility, the availability of streptokinase. And he also checked the thrombolysis register. One patient had received thrombolysis the previous day. We called up the hospital where the patient had been referred. The patient had received a pharmacoinvasive angiogram, and the procedure had been done, and the patient was doing well. Then they visited a level 2 hospital, Tiruvallur Medical College Hospital, wherein a policeman had suffered RTA, had suffered a mesenteric injury, with presented to the system in shock, was taken up for surgery within 2 hours, and the patient had recovered. The team visited the policeman, inquired about his health, and expressed their satisfaction over the standard of care provided to a patient who presents to the system. And after the level 2, they visited the level 1 hospital at Madras Medical College. This was done yesterday. After seeing them off there, I came over here for this meet to meet you all, only to share with you all what is going on. THAI as a program, after over 6 years, despite the best efforts, compared to 2019 to what it is today, despite an increase in the number of accidents by 2.4%, 2.3%, there is a reduction in the number of deaths by 1.4%. Of course, what we have achieved is only a very marginal 1.4%. When I say marginal, the fact is, this was the team Telangana along with our chairman, Special Task Force on Road Safety, discussing how to implement it in Telangana. And they asked for his opinion. What is the best practice that we can take from Tamil Nadu? Was a question from the delegation, to which our chairman answered, truth is the best practice. Because road traffic accident, everything is a story. From the FIR, for insurance claim, cause of accident, everything is a story. We have become so much used to the falsehood that truth has distanced itself so much from us that we need to endear ourselves to truth, and may truth guide us also in establishing emergency medicine not just as a department, as a lifestyle. Because this is a recent incident from Kerala. One of our boys, one of our colleagues' family, what had happened was, the boy had a quarrel at his home, and he chose to take his bike and travel to Tamil Nadu. He suffered a major accident near Dharmapuri. He had suffered a major accident, and he was found unconscious, no attenders. He was brought to the Thai facility. And this is the letter from the father and after 6 days. I would like to place on record my heartfelt gratitude on the service rendered to my son. He was brought to the emergency department of Dharmapuri in an unconscious state after a road traffic accident on 9th morning, March, with no attenders or caregivers. He developed hypoxia in the ED department and was promptly intubated and put on ventilator. We were contacted by the ED in charge, who also reassured us that everything is done and calmed us. Over the next 6 nerve-wracking hours on way to Dharmapuri, the dean, the ED physician, everybody called us and reassured. I thank my son has not suffered brain injury, and my son is recovering at Trivandrum now. This was a letter from one of our own colleagues. Why I'm just telling this is, emergency care is not just a science. It is something beyond science. It's not just skills. It is beyond skills. It is not just techniques. It's beyond. It becomes so when we mix our knowledge with kindness. When we serve our technique, when we serve our skill with compassion, whatever we do, when we serve with courtesy, that alone is going to make the difference. Why I'm just telling these pointers? As our Madam DME pointed out, our postgraduates, they also send them to corporate hospitals and private medical colleges for training. And one of the students who made this observation to the teaching faculty there was, sir, everything is fine. We have every equipment, everything. But we are in a state of irritability when patient comes. We are angry. We don't treat them with courtesy. But when we see here, you are so much courteous towards the patient. This gap, the student was honest enough to point out, and I am humble enough to place it here. What we need to tell our students is not just science, not just skills, not just techniques, something more and something beyond. And that is what is going to make us better doctors. And a better doctor will be so only when he is a better human. And unless that is ensured, all our efforts will land up in futility. Let that not be the eventuality. And as I said, the time is muscle, time is brain, time is everything. The other dimension of time is prosperity, and time delay is poverty. When faced with an emergency, when a patient lands up in the emergency department, and the patient is not acted upon in time, and if the patient, out of emotional disconnect, resorts to move to a private hospital and resorts to out-of-pocket expenditure, that has the potential to place that family in abject poverty henceforth, because an emergency is the doorstep to poverty. It is the gateway to poverty, and if acted upon time, our public health system, when strengthened and when caters to the emergency patient with sensitivity and preparedness, along with compassion and courtesy, that is the day we all will feel proud of. Thank you very much.
Shall I request you to hand over the momentum? I think this is an excellent. You are very passionate about the whole thing that is seen in your talk, and there are a lot of questions, I'm sure. I don't know, for the want of time, can we entertain one question?
Yeah. We'll take 1 or 2 questions, no problem. We'll take 1 or 2 questions. Madam is also there.
Can
1 or 2 questions.
Because the time model is something that has been talked about a lot. And as Sir was rightly mentioning, there are no boundaries for emergency care. And all that is required is a timely management. And it is seen that even from Kerala, what I was talking to Madam, the border states, border districts always have a problem between patients who are from Tamil Nadu or from Kerala, getting the proper attention. So we need to work on it and improve our emergency care system.
So regarding the borders, I think we technocrats are ready to tackle everything. Only thing we have to discuss with our bureaucrats like our Principal Secretary of Health and Family Welfare of both the states, so that border dispute can be. This is for, we are here to save lives. Oh, I think we can discuss with them. Oh.
Thank you very much.
Thank you, sir.
I thank the chair for permitting me. I am rushing to the airport. My flight is at 1:40. I thank everyone for the wonderful opportunity, for the excellent audience. And we need to team up and work together as a team for the whole of the country, in every other part of the state. We need to step in for those who are trying to establish. We need to shake hands, share experiences, stand up for the increasing trend of emergencies across the country. Thank you very much.
Thank you, sir. Now I invite our chairpersons, Dr. Narayan and Dr. Vishwanathan, to hand over the memento and certificates to the speakers. I now invite Dr. Krishan Kumar, CMO, SAG in DGHS and Director of National Organ and Tissue Transplant Organization, to give a talk on National Program for Integrated Emergency and Trauma. I invite sir onto the stage.
Respected chairpersons, all the luminaries of emergency medicine, all the stalwarts and the rising stars and the coming stalwarts, future stalwarts of emergency medicine. Very good evening to you. Yeah. You can. First of all, I will like to congratulate Team KEMS and especially Professor Vishwanathan for organizing such a wonderful summit. You have done a great job indeed. And secondly, second thanks is for giving me the opportunity to listen each and every presenter before giving me the chance. Now I can come up with my comments. I have seen each one of you. So thank you for that opportunity also. So my talk, see, I am not here to teach. I am here to learn. Being sitting in the helms of the affairs, now I am out of the walls of hospitals, which I did for last 30 years. Now I am at a place where I used to think, why better can't be done? So I think I am sitting in that place. So it's my turn now to do something good. In the beginning, I will come up. I am now, I think, contradicting few well-known truths. One is, what's in name? No. Name signifies many things. Just by creating or changing the name from casualty to emergency medicine has created a lot of difference. Emergency medicine, now what has done this change in name? It has given the ownership to the patients who was nobody's baby, or as told by my previous presenter, that everybody bodies is actually babies is nobody babies. So at least there is a department who is there to take care of all these people who want immediate care. Second is what this change in name has done. It has started a movement from silos to a holistic medical care. Till now, what we were doing is we were looking at a patient from a specialist point of view. ENT was looking at his part, Buns was looking at their parts, Ortho was looking at their parts. Now somebody is there who is looking at a human body as a whole. So just this change of name has started these changes. Secondly, as my previous presenter has said, that emergency medicine is a recently born branch. No, I don't agree. I think medicine started with the emergency itself. As she was told in the history itself, who was the first patient who was treated? It was a dislocation of mandible. It was an emergency. So medicine was born out of emergencies, out of the pains and out of the woe. Somehow, with the progress of time, with the advancement in medical sciences, we move from person to the organs, organs to the tissues, tissues to the micro tissues, then specialization, super specialization, super specialization, and somewhere whole individual was lost. So now what we are doing, we are going back to the history. So time has completed this circle from where we have started. Now we are coming back to that one. Now I start with my presentation. So Dr. Vishwanathan, what you have done, you have created all of us here who are at the helms of the affair to change the things. Niti Aayog is sitting here. So is the directorate representative is here. So are the people from the AIMS who are the stalwart in the field. So are the two states which are the front runners in the medical emergency care right now. And so are our young people sitting there and all the stalwarts sitting here. So thank you for this. So what I am presenting here is what I have learned in these 2 days, that everybody was coming up with a line that views given by, expressed are mine. No, I can't say this. I am a person, I can't say that these views are of the ministry also. Some are of mine. Each and everything which I am standing here and telling you is going on, but at the same time, there are few comments which are my visions, my passions, my dreams. So the painful thing is at the bottom. I think Niti Aayog sir has presented this. Look at this paper. When this paper was published? This paper was published in 2004. So in 2023, we are still quoting the figures of 2004. Why? It means there is something wrong, that we are not collecting the data. We are not good at collecting data. Everyone knows it. So first thing in this slide is, let us start sharing data. Data is the science which tells us where we are, or unless or until we know where we are, we can't move ahead. So now this is why trauma and emergency is a priority. We all know this. Unexpected out-of-pocket expenses, time sensitivity is there, and SDG targets are also there. So let me go back to the history. So far what we have done. This journey of emergency medicine or a trauma or whatever we call it, it started in 9th and 10th year plan. It started as a pilot mode. Then came the 11th 5-year plan. Then we just started looking at the trauma care, especially in the government hospital on national highways. At that time, 116 trauma care facilities were supported. Then came the 12th 5-year plan. Capacity was again raised. another 80 trauma care facilities were started. Then came the National Program for Prevention and Management of Trauma and Burns. Look at it, what we have done. We have now integrated trauma with the burns. So here the integration started. And now in 21-26, where we have moved, we are now going with the emergency medicine. It is not only trauma, a holistic approach towards the emergency medicine, which is inclusive of everything. Either it is medical emergency, either it is surgical emergency, or it's a poisoning, as the Thai people have presented that they have 6 beautiful pillars of that beautiful building. So everything is being covered here. Now we are moving from a trauma-only approach, burns-only approach, to a holistic approach at a emergency system. So what so far we have established this. These are the trauma care facilities in our country, which our government along with the state governments have started. So total are 196. So this is the roadmap. So now, after doing all this, we realized, even whole world realized, that just working in silos will not do. Let us take a holistic approach. WHO started with this. So are we. So we studied along with Niti Aayog, and AIMS trauma team is sitting here. They all studied along with Niti Aayog, and this document was studied, and we just started where we are right now, what are the deficiencies, how to move ahead. So this is the government-led initiatives which have been started. National program is started, then PM Abhim scheme is started, National Ambulances Services has also been started, and we have started building capacity of human resources, and norms for public health facilities were also given. Now, where we are moving? So we are now moving towards transformation of emergency and trauma care based on the 3-pillar approach. What are those 3 pillars? One is improving the ambulance services, then improving the emergency care health infrastructure, and then 48 hours cashless services, as Sir has already, Dr. Venkat has already started. So we are now working on it, and in near future this will be a reality in Pan India. So what are the 3 pillars? These are the 3 pillars. So we are working on it. So what is the pillar 1? Transforming ambulance services to global standards. This is the pillar number 1. So how we are going to do it? What we are envisaging is, in the coming years, in the coming 5 years or so, we are going to double the number of ambulances available in India, along with integrating all the ambulances which are present elsewhere. So what is envisaged here is, by increasing the number of ambulances, we are going to reduce the ambulance time from 20 to 25 minutes to 9 to 14 minutes. Then these services are envisaged to be commanded by a center having 24/7 availability of doctors for teleconsultation and triaging. And then emergency medical technicians will be available in each and every ambulances to take the care of the emergency patients during the transit. And then there will be a Pan India 108 number to trigger this system. So this slide has already been presented by Sir. So this is the slide. Here we envisage how we will be moving. So it will be the patient. Patient will either by the call of the patients or by the call from the bystander, that ambulance coordination cell will be activated and ambulances will be dispatched, and it is envisaged that response time should be less than 9 minutes, and then GPS enabled ambulance will be reached. And here these two blue things are very, very important. So during the transit, this emergency technician will be coordinating with the command and tele-coordination center. What is the patient, how to do it, is there any backup required, where to take the patient and how. So online telemedicine will be there. They will be guiding this person so that during the transit, the patient can be taken care of. And then patient will be reaching the emergency, and in the emergency care, there will be protocolized care. Now coming to the second pillar, improving emergency care health infrastructure. So emergency care departments at district hospitals and medical colleges are envisaged. So it is envisaged that each district hospital, each medical college, and the process has already been started with the declaration from the NMC mandating that each and every medical college must have a emergency medical department. So this ball has already started rolling, so we are moving towards it. The only thing is here, what I will like to say is, till now, we have got around more than 66 medical colleges, and we don't have enough number of trained emergency medical physicians or doctors who are going to take care of these emergency facilities. So for this, NMC has come up with a proposal that till another 5 years, they are going to allow doctors from the 5 specialties, that is anesthesia, surgery, orthopedics, then it is medicine, and one more, respiratory medicine, to take care of, they can opt for the faculty positions in this department. But the problem here is one big problem which I have just observed. See, the syllabus, the curriculum, whatever we say, given by the NMC is too basic, and it is becoming difficult for the surgeons who has done MS in surgery, or the people who has done post-graduation in anesthesia, medicine, respiratory medicine. We are asking them to provide the primary care. It is becoming very difficult once we are going towards that. There are few exceptions like Dr. Vishwanathan and Dr. Boy, a physician sitting in a trauma center, a surgeon looking after the emergency, but not all the surgeons and all the people who have done post-graduations coming to provide the basic services. So we need to look at the curriculum. Curriculum need to be revised. Here we will require support of each one of you so that we can come up with a curriculum which should be good enough to enthuse these specialists to come up and own these departments. This was the survey done by the AIMS Trauma Center. Already this has been discussed that we have found, this shows that we are very serious. We are looking at the things where right now we are, and based on these all observations, we are moving forward, and we are coming up with the 3 pillars approach. So these were the fallacies, these were the problems with the present systems. So we are moving towards solving these problems. So now, what are the opportunities here? We are also looking after Indian public health standards are already there. We are standardizing all the facilities. Minimum standards need to be there. And we are also coming up with provisions to care for burn patients at all the facilities. And now, as I have told, in 92 district hospitals and 200 government medical colleges, CT radiological services are being envisaged along with the human resources over the period of 5 years. Now, what is the pillar 3? It is provisioning 48 hours cashless treatment for road traffic victims. So why this pillar? Because 80% of our services right now are being provided by the private health sector. And it is not possible for a person who is lying in the road to afford the medical treatment at a private hospital. So a system need to be devised where at least first 48 hours till the patient is stabilized need to be free of cost, and government should be looking after, or some system should be there to take care of this emergency time. So how they are proposing is, so we have 60% of the vehicles which are already insured. So insurance company will be providing this cost. Then uninsured vehicle will be done in these cases, and in hit and run cases, government will be providing cost from its exchequer, and in case of uninsured vehicle, the owner will pay the cost of the medical treatment. So this is what I have with me. So other issue which are being taken off, wearing of seat belt is being made mandatory. We are also working with the MORTH to ensure roadworthiness. Use of helmets are being ensured, and enforcing checks for speed limits are being stringently put. So these are the demand side concern. Pre-hospital care policies need to be there. Capacity buildings of doctors need to be there, and IPHC norms at least need to be implemented in all the trauma care, emergency care facilities. Other initiatives are, we are promulgating good Samaritan behaviors among the public. Also looking at the behavioral change at the school, at the young age also. We are going to the schools and training them. We are involving NCC, voluntary and self-help groups. And we are also mulling about how to create standalone pathways for ambulances on the roads. Right now, we are able to do some progress in this. You must have heard about the green corridors for organ transplantation. So, transportation, we are also looking at this. And then we are proposing to have first aid centers at all petrol pumps on the highways. We are also scaling up. Now here, unless or until this emergency care is it cannot be only taken care at the hospital level or at the health care level only. It need to be a public movement. So it is the peoples which are standing at the site of accident need to take care of the person first before whatever time I can summarize, I can shorten. Still it will take some time. So first responder paradigm, we are planning to involve communities, our police personnel and the schools, universities, all the youngsters, and we are providing them training in the basic life support care. First we are moving towards making basic life support training at all the medical colleges. So and then coming to the government hospitals, public hospitals, and then compassion only care for the common public. Then we are also engaging with the NHAI. We are also linking with the disaster management authorities. Opportunities are India has to develop a world-class ambulance and emergency care system someday. Let us build it now. Lack of strong emergency ambulance trauma care system is the missing block between ABHWC and ABHPMJY. Under PMHA beam, inpatient critical care units are being established. Developing entry point emergency departments will ensure prompt triaging and immediate stabilization and care, complementing each other and completing the loop. Noble objectives are there. We are going to save the life, averting catastrophic expenses, and wiping the tears of lack of citizens. Thank you very much.
Thank you so much, Dr. Kishan, for your elaborate talk. We will take the questions at the end of
Okay, respected chairpersons, dear friends. So I'm going to talk about the building blocks for the operation management in the emergency departments. So as we know, we are the largest population in the world with a population of 1.4 billions. And the emergency departments are the most crucial part of the healthcare system in our setup because they provide the emergency care to the population. Whenever they require urgent care, the person has to go to emergency departments. Thank you. Now we know that the 5 topmost conditions which cause death and with which the patients come to the emergency departments include stroke, acute myocardial infarction, cancers, chronic obstructive pulmonary diseases, and road traffic crashes. Now, these patients who come to emergency departments, they often die in the emergency department because of lack of operations. And these people who die in the emergencies, they can be saved if we have proper operations in our emergency departments. So our operations in the emergency departments are diverse, just like our Indian conditions. We say with the pressure in our emergency departments, they are increasing over the period of years. For example, we don't have any data available to us, but the estimates say that we see about 2 million emergencies every day in all over countries. We often say that the emergency departments, they are very poorly organized, and one of the topmost reason is that we are overcrowded. But what Lou Holtz, who is a famous American footballer, he said, it is not the load that breaks you down, it is the way you carry it. So for the emergency departments, it is the operations which help you in day-to-day functioning. So that is, if the operations are very efficient, you can decrease the mortality, you can decrease the morbidity, you can efficiently function in the departments. So this brings us to the topic of emergency operation department operations, which refers to procedures, protocols, and practices which are followed in the department to provide timely and appropriate care to the patients who require urgent medical attention. The primary goal of ED operation is to save lives and reduce suffering of the patients by providing rapid assessment, rapid diagnosis, and rapid treatment of acute medical and surgical conditions. Now here I would just like to add what Dr. Krishna Kumar said about the curriculum for the emergency medicine the course. Now, as you said that the faculty is derived from various specialties, medicine, surgery, orthopedics, respiratory medicine, anesthesiology. Now, Indus EM was basically, it was a collaboration between the specialty from EDs of America and India. So it has come out with a program called Ashwamegha. It is a collaboration of WHO Collaborative Center from AIMS and AIMS Nagpur. So it has devised a faculty development program for faculty of these programs, these faculty of anesthesiology, surgery, medicine, respiratory medicine, and anesthesiology. This is a one-year program. So these faculty can be trained in managing the operations of emergency medicine department, as well as to train the residents of emergency medicine department over a period of 1 year. So this is not that we are not training these people. So they can be trained to have the operations of Department of Emergency Medicine, and they can also train the residents of Department of Emergency Medicine over a period of 1 year. So what the Department of Emergency Medicine requires is policies. They should have strong policies. For example, the department requires strong policies that includes nuances and address various challenges encountered in the emergency department. One of the important kind of problem with the emergency departments face every day is the admission of a patient with multiple problems. Like for example, a patient has come with COPD, with myocardial infarction, with say gangrene of the limb. Now the patient would be seen by various specialties, a surgery surgeon, a cardiologist, and a medicine person. Now the department has to make policy, the person has to be admitted where. Now for this, the department has to take a call beforehand only. The department head has to make a call, in the sense they have to call the HOD of medicine, surgery, cardiology beforehand only to make a policy where such a patient should go in case such a patient comes to emergency. So they have to make a policy where a patient with multiple discipline problems should be admitted in case a person comes with the patient to the emergency with such a problem. The policy should be flexible and adaptive based on the feedback. Now it is very important that feedback from the multiple stakeholders should be taken. For example, Dr. Akshay had a quality improvement program on patient with chest pain. So it was a program to decrease ECG time when the patient comes from the triage to the treatment area. So in this quality insurance program, one of the orderlies gave a very important suggestion: how to transfer the patient from the treatment area to the cardiology ward. So this was taken into consideration, and the patient was transferred to the cardiology ward within a period of 2 minutes instead of 5 minutes which were taken before that. So that's why the feedback from various stakeholders is very important. The policy should focus on providing evidence-based and best treatment practices, and that is again very important, of course. These are various steps in ED policy development. The problems should be identified, and motivation for change should be there in the stakeholders. there should be a policy team which should be in place. The policy should be created, it should be implemented, should be monitored, and then policy should be placed in action. These are 6 important elements in ED policy development. It includes the local data should be collected. It should be collected from the literature review or from the local data. Then determine whether this is applicable to your own institute or not. Suppose you have imported from some other institute. You see whether this is applicable to your institute or not. Suppose I am working at AIMS and you have a policy at this Southern Hospital. I must see whether this is applicable to my institute or not. And again, we see whether this is also applicable. This is consistent with my other policies or not. Also seek whether this is the approval from other stakeholders or not. And then take care then implement this and see whether everybody is on board or not. The other operational block is the triage. That again everybody is talked about triage. So triage is a very important area. It should be manned by a trained nurse or a trained doctor who should know how to triage, and the triage time should not be taken, it should not be not more than 2 minutes or 3 minutes. It is a very high efficiency area. It should not, it is a zero, basically it doesn't cost much. Zero cost, high efficiency area. And Dr. Akshay has made a protocol, that's the AIMS triage protocol, ATP protocol, based on 3 parameters. That is the AIMS physiology, that's the altered physiology, based on altered physiology of the patient. That's the second is the time, that time sensitive condition, and the third parameter is other urgency conditions. And based on that, we have the AIMS triage protocol, which has been tested on about 13,000 patients. And it is a very high sensitivity in identifying patients who ultimately either have ICU admission or ultimately died. The other operational block is the registration counter and MLC counter. Now, it should not happen that patient who requires a medical case should go to a police station first, particularly patient with a simple injury. Should not go to a police station first and then comes to the hospital. Every patient who has a medical legal injury, even if it's a simple injury, can come to the hospital first, gets his treatment done. The police can come to the hospital for that. The other thing, an important operational block, is the infrastructure of the hospital, which should be adequate for the patient as well as for the family. There should be adequate waiting hall for treatment of the patient as well for waiting for the patient's family. This is for the NMCs, that there should be at least 24 trolleys or beds, 5 for the green patients, 15 for the yellow patients, and 4 for the red patients. In addition, there should be 6 beds for the ICU. Now, it is very important here to say that these 6 beds are only for the transit beds. They are not for the admission of the patients. Now, there are many anesthetists who are working in the emergency department as faculty members. So, these beds are not only transit beds to decongested beds. They are not for admission of the patients. They are only transit beds to decongested beds. They should be vacated within a few hours by transferring the patient to the hospital ICU beds. Because many patients may require emergency surgery, so there should be one operation theatre in the emergency department and one plaster room to take care of the patient with orthopedic injuries. It is desirable to have a decontamination area outside the ED because some patients may have some chemical exposures. So this is also one important thing which is required by the code, but many hospitals don't have it. That is a one-stop center, where women with sexual violence, sexual assaults, sexual harassment, or even acid attacks, they can report and they can be examined separately in a room which is called one-stop center. Now this area should have 2 rooms, one for counseling, one for examination. I don't know whether Dr. Vishwanath, you have this area basically is as soon as the women come, the woman should be directly taken to this area for examination. She should not mix with other patients in the ED area. The other important operational area, I think, is the equipment. The ED should have adequate equipment to manage the patients, which should be from the basics like bandages, IV fluids, to more complex equipment like ventilators, defibrillators, cardiac monitors, infusion pumps, nebulizers. So all the beds in the ED, whether they are green, yellow or red, should have central oxygen supply and suction areas. All the red areas and ICU areas, beds should have high-end cardiac monitors with facility of monitoring carbon dioxide and end-tidal carbon dioxide. They should have ICU ventilator facilities which can ventilate neonates as well as the infants. They should have defibrillators, and they should have point-of-care laboratory which can monitor ABG, monitor lactate and cardiac enzymes. An important thing which I have not written here is ultrasound machine. Now, every emergency medicine must have at least 2 ultrasound machines, which should not be shared with other departments. Very important for the emergency departments. All the emergency life-saving medicine should be available in the EDs as per the National List of Emergency Medicines. Now, this is another important aspect, the flow of patients who are coming to emergency medicine department. It is very important that there should be efficient flow of patients in the emergency department, right from the patient, from the triage to the treatment area to the discharge of the patient or disposition of the patient. So no patient should be stagnating in the emergency department because the patient is waiting for a bed in the ward. Maximum time for the patient to wait in the emergency department may be maximum to 6 to 8 hours. If the patients remain in the ward for more than that, the care of the patient will suffer, the straining of the resident will suffer. So there will be processes in place for the management of time-sensitive conditions like stroke, heart attacks. So if a patient with suspected stroke comes to the emergency, at the triage area only, there should be processes in place. The triage nurse or triage doctor immediately alerts the stroke team, alerts the CT MRI team, he assesses the ABC of the patient, he gets his blood pressure, the pulse rate, the blood sugar, he assesses the cardiovascular system, he sends the blood sample for various investigations, gets ECG done, and send the patient for the CT scan or MRI. So that should be a standard operating procedure for a patient coming with stroke, which should be done within a few minutes. Hospital and including the EDs are a very sensitive place for the fires. So there should be a fire safety procedure in place in the EDs, and there should be regular drills for that. The staff should be knowing about do's and don'ts in case of a fire incidents. There should be plans in place in case of fire incidents. There should be plans in place displayed at prominent place in the EDs for evacuation. Human resources are again a very important part of emergency department. There should be adequate human resources available in the department, which include faculty, residents, nurses, the paramedical staff. Security is an important issue in the emergency department. And as I said, we have a very important faculty development program, Ashwamedh. Communication is an important part of emergency department. Communication between the healthcare professionals as well as between the patients and the family members is important. Communication is again important at the time of handover and takeover, because that is the time when errors occur. So quality improvement, Dr. Akshay already talked about quality improvement. This is again an important part of ED. There are other building blocks of EDs, which include the skill labs, the patient safety improvements, electronic health improvements, records, and the disaster preparedness. So just to summarize, we have planning, infrastructure, and personnel as the three pillars for the operations of EDs. The blocks are physical materials, but the main fuel for drive, which drives the ED operations, are the human factors. And men with fire in belly and passion will drive any work with gold. And there is always a scope for improving any system, and let us all work for it. Join Ashwamedh Pro Faculty Development Program to learn ED operations. Thank you.
Thank you so much, sir, for an entertaining talk. And
right. Any
we are
questions?
grateful, sir. We'll have the discussions combined way if you have time. We request the next speaker. Please come on
we
stage,
now
ma'am.
welcome Professor
to
Dr. Padmaja
share the
Durga.
Telangana experience. Yeah, please.
We now welcome Professor Dr. Padmaja Durga of Nizam Institute of Medical Science, Hyderabad, to speak on Telangana model, state initiatives, hub and spoke model of emergency care.
Good afternoon, chairpersons and all the delegates here. It's a great privilege to be a part of this program. The mainly strengthening on the integrated emergency and trauma care services. I think since yesterday and today we've been hearing a lot on development of emergency care and also how to strengthen the emergency medical care. And I thought most of the focus is still on the level 1 epic centers like AIMS or on the tertiary medical centers that are in the medical colleges. But then what we realize, or what has been emphasized again, is the chain is as strong as the weakest link, and the weakest link lies in the rural areas. So improving emergency in the rural areas was one of our focus. So I'm happy that the author of this book is here with us, Dr. Nair. So this is on strategic directions to integrate the emergency medical services into the primary healthcare center. So this is one of the most important things for us to do, because most of our patients in India reside in the rural areas and have access mostly to the primary care centers. So as we all understand, emergency medicine is all about time, timely recognition, treatment on time, and also the equity, the treatment to everyone who needs it. And this is where we need to improve our healthcare systems. And also, most of the time, patients have access to the primary healthcare centers or the rural area centers, and they also prefer to be treated in those centers itself. And therefore, continuing the treatment of these critically ill patients in these systems is also important for us. Where do I focus on? But unfortunately, most of our primary care centers are focused on the preventive initiatives. But then preventive initiatives, the government goes to the patient or the person, but the person comes to the hospital only when they are critically ill or when they are injured. So there are a lot of difficulty in these sick patients to access the tertiary health care. One of the most important things, as we were talking about, was the availability of ambulances and also the distances between the tertiary and the primary care centers. And most common emergencies that we see are like acute injuries, infections, exacerbations of these non-communicable diseases like probably COPDs or hypertensive emergencies and diabetic emergencies, and also things like stroke and MI. And in most of these things, we understand that the time is the most important thing. And the timely intervention in these is probably the mantra for success or the improved outcomes. So in Telangana too, as in any other part of the country, most of the Telangana is rural, and then the access to the tertiary healthcare is only in the form of one metro city and about 6 two-tier cities which have some medical colleges. So there's only one level 1 trauma center in Telangana, and access to this is again very difficult. So for me to travel about 20 kilometers in Hyderabad takes about half an hour. So imagining that someone would arrive from a rural area to Apex Center in Hyderabad would probably, within the golden period, is almost an impossible task to think about. So most of the patients have access to some of the vital hospitals that are there in the rural areas which cater to the general care. And then they also provide some form of emergency care, but it's not a structured care. So we thought that providing or enhancing this medical care in these hospitals would actually be important. Since most of these hospitals serve more than 70% of the population, and thanks to COVID, some of these hospitals are also now provided with ICU beds. Most of them, I think Tata Trust has also supplied some ventilators and monitors and syringe pumps to these level 3 hospitals as well. So they have some sort of facility which can be used to take care of these critically ill patients. And there are some district and area hospitals which are probably equipped, but then the human resource was one of the major limitations. So the human resource was mainly focused on the tertiary care or the medical colleges and the Apex centers. And we understood that NIMS were the common destination for most critically ill patients. And this is the picture that I borrowed from WHO, and then even that picture shows that probably the final access to the tertiary care was what was focused upon in most of the things. But then accessing this, as we understand, is one of the most difficult things. So when a person, where the patient first enters the primary care, the physician there has a most important dilemma, like whether to keep the patient there in that hospital or to refer him to another hospital. Now, referring is easy or thought because that's the easiest path to take, but then getting an ambulance for this patient is very difficult. And also, like if you don't have a public ambulance, then transferring this patient via private ambulance is going to be an expensive affair. And then where do these people reach? They're going to reach tertiary hospitals. And not all tertiary hospitals that are available or accessible to these patients where beds are available are going to be public sector. So they probably end up going to a private hospital where they, as the previous speaker was speaking, would end up paying the whole savings that they have had. And what about retaining them in the same hospital? One, the most important thing is the expertise. Especially a 24-hour care for these critically ill patients is something that is lacking in most of these areas. And also, like, when you keep the patient, again, deciding on when to refer them if the patient deteriorates is also a difficult decision to take. But most of the time, the patients retain in these hospitals because they either do not have the facilities or they do not have the finances to go to the tertiary hospitals. So most of the time, the physicians have to probably retain them there and treat them whenever it's possible. So what we are looking at is providing an integrated emergency care service at the primary care level. And why is this important? It is important because, as we said, most of the problems are time sensitive, and then it's the primary care that's most accessible to most of the patients in rural areas. And therefore, it is important that we build this primary emergency care with a high quality. So it is, the importance of this is to provide an equitable health care to everyone. So unless the quality of this emergency care in the primary hospitals is good, we cannot provide this. And then there was some silver linings that we saw because of the COVID. One was availability of the equipment, and then two, the availability of the telemedicine. So we were using this for some of the chronic medical conditions, and then we thought, why can't we use it for acute medical conditions as well? So it was a decision that was taken by the government of Telangana in collaboration with the NHM. With NIMS as a hub and the spokes as the level 3 hospitals to develop a hub and spoke model for emergency and critical care. So this was an initiative like a telehealth program where we could provide this emergency critical care beyond the boundaries of the hospital. So with this hub and spoke model, we connected with the level 3 hospitals at various places in Telangana. And the primary principle was to use this technology in order to provide the emergency medical care through telemedicine. So we also know that there's a paucity of specialized healthcare people in these peripheral hospitals. So this whole concept of this tele-ICU was to fill in these gaps so that there is a convenient on-demand access of the specialists to these doctors working in the peripheral areas. And also it was important for us to develop some systems of care so that even without the hand-holding and the oversight, clinical oversight from the hub, these peripheral centers can at some point work on their own. So we started this program in June 2021 with Sirsila as one of our center, and this happens to be a constituency of one of the health ministers, so it was very easy for us to start up this program, and we worked on it for about 6 months to understand the nuances and also develop some protocols for us to work on this. And currently we have about 8 hospitals with about 60 or 70 beds, and we have so far catered to about 4,500 patients through this program. So as you can see here, like one of the centers, Utnur, actually is about, how does this work? So that's about 250 kilometers from Hyderabad, and then it's not connected by any major roadways to Hyderabad or even to any closest level 2 center. So providing healthcare in these centers was one of the challenges, and probably the EICU could actually fill in those gaps. So you can see that most of the peripheral centers that we have, this pointer doesn't seem to be working, but we're all present in some rural areas or sometimes even in tribal areas where the access to the healthcare was very limited. Though the equipment was there were some physicians working there, but then they were not really used to working 24/7 for emergency care. So we initially started to address this shortage of the specialists, and also we trained them in order to enable these patients, doctors to manage these patients on site. So the whole idea was to minimize the tertiary referrals so that we can decongest the urban tertiary hospitals, and also there's a lot of healthcare saving or out-of-pocket expenditure when these patients are not referred to the urban healthcare. So this would probably improve the rural healthcare and deliver healthcare through technology. So the major benefits that we envisaged was that we would probably enhance the care in the peripheral health centers, and through this model we can actually have a clinical oversight from the hub to these spokes. Though the hub was not a supplement for the healthcare workers, but then it would probably fill in the gaps, especially in the night times when we have emergencies coming in. So with NIMS as a hub, we started a 24/7 monitoring that was designed to treat these critically ill patients that come to these peripheral hospitals. So there was a 24/7 accessibility of the hub doctors to the peripheral doctors, and they could contact us anytime that was required. And so as and when the patient comes, or if they have a difficulty in treating the patients, they would contact us. And also the nurses in these peripheral hubs, peripheral spokes were empowered to contact us directly, because most of the time we do not expect doctors to be 24/7 present. There's only a single doctor for the whole hospital who's catering everything, who's multitasking as a casualty medical officer and also as a ICU physician and also runs the OPs. So at this point, the nurses can actually directly contact us and also take the consultation. So NIMS had some trained physicians, and that is how we could extend the care. And also the advantage was that the peripheral hospitals could take consultations from the specialists that were present in NIMS. So there was a 24/7 access to the specialist consultations as well. So what we developed was, there was a Cisco system through which we could communicate two ways. I'll show you some pictures in a while. So we could actually see the patients who were admitted in these peripheral hospitals through the Cisco system, so that we could also evaluate these patients whenever it was required. So this was a model of the EICU, where you have a command control center, and through the system we could communicate with the other spokes in the EICU. So we started with all level 3 centers and then we categorized them into 3 components. Most of these hospitals were either area hospitals or district hospitals. So some of them had a 10-bedded ICU with a full-fledged HR, that is a 24-hour working HR. And some of them actually had a 10-bedded ICU, but then they didn't have a 24-hour coverage of the HR. So they depended mostly on the referrals. So we were trying to minimize the referrals here and enable them to deal with the emergencies here. And some of them were rural hospitals like Utnur or Etur Nagaram. Even I haven't heard of these places until we really started working with them. And these started with 4 to 5 beds and then mostly with the teleconsultation with the nurses so that some of these emergencies that come in can be handled by them. So when we started this hub and spoke model, and then we identified the toolkits that were required for the medical and other emergencies, and also developed some protocols and monitoring. And this was important because we had to understand the rural requirements and develop protocols according to what they had in place, because it's not very easy to change the whole system as such. And then we developed some software technologies and also some means of transport. So we were talking about pre-hospital information, and then because we were triaging these patients and referring them to NIMS, we could actually get a pre-hospital information or keep the system ready for them. So we developed some toolkits for different levels of these level 3 hospitals. So this is the EICU that we have at NIMS, and then we can actually look at these patients and consult them, and whenever some critical examination is required, we can also zoom in to see what the patient has, and it also gives us access to the patient monitors and also the other systems. So a lot of times when something was going wrong, we could identify that, or sometimes they needed some help in adjusting the ventilators, which could be done remotely through the systems. And this is the Cisco system for calling. So both ways, like the doctor on the peripheral end can have an access to the Cisco system so that they can communicate both ways. And this is one of the consultation that was going on. Wait. One doesn't seem to be playing. Anyway, I can't get to the sound system. So this is how we could consult on a daily basis, and also whenever there is a new patient arriving, they would also be consulted through the Cisco system. And then we had some nurses who would do the database entry for us, and we were also involved in the development of the database. So what we could achieve in this 1 year was, first we started with the training of the HR. So all the HR spokes in the HR were called in to train in various skills that were basic skills like intubation and other things, and also we trained them on some advanced skills in those centers that had an ultrasound. We also trained them on use of ultrasound, and then we conducted a regular weekly programs for these people, because most of the time the HR keeps changing there and we need to update them on a regular basis. So we had a regular weekly program also for them on various aspects, like what are the, depending on the common problems that we see, especially like toxicology, stroke were the common things that we see. So we have focused our programs on that. And also we developed some SOPs that were probably more topical and for those areas. The most important things that we could achieve was things like management of sepsis and stroke, and also implement some antibiotic stewardship programs. And we were talking about these mortality morbidity reviews, and this actually helped us to understand the problems that were there and also provide solutions for that. So this is how the workflow went. So we had done the capacity building, and also through daily rounds there was some knowledge exchange, and we had some focus workshops, and that helped a lot. And so most of these non-specialist clinicians in the rural hospitals were able to adapt to some latest evidence-based protocols because of this constant engagement with them. And the other advantage was these rural hospitals were able to leverage the program and also upgrade their pharmacy. So it was easy for them to tell us, and then we contacting the government in order to bring in some changes in the equipment and the drugs. And the most important thing was the decision making. So because they were in contact with the people in the hub, and they could make the decision making was easier, and also they could do it with more confidence. And the team at the hub was also involved in development of a database, which would enable us to actually have a two-way system which we could interact with the vital signs, have a medication table, and also have a timestamp for all the events that were happening. So this is how the dashboard looks like, which gives us every patient's information can be accessed from the dashboard. And it's also easy to gather the data and analyze the data once we have this information data stored. So this is the data that is captured from there, the details of the patient, as well as, you can implement some clinical scores and then have the treatment plans into that database. So the most important benefits were that patients were able to get treated in their own places. And as you know, transfer is not just about transfer of the patient, the whole family has to come to a nervous center. So a lot of unseen expenditure that goes behind this, and that could be minimized. And also because the patients were treated and stabilized before being shifted, the mortality rates had also come down. So I'll just, and there was a lot of confidence among the doctors in the peripheral areas. And because there was a lot of awareness about this program, it also created some power to the doctors there, and also the patients felt confident to go to these rural areas for treatment. So you can see that when we started, the numbers in the ICUs were low, but then as we went on, the numbers kept increasing, and now we're able to have around 80% occupancy of all the beds that are there in the rural health centers. And these are the most common problems that we could treat. The most important difference made was in terms of poisoning. So the timely intervention for poisoning really made a difference to the outcomes. The other common thing where time sensitive is epilepsy, and so that is where the outcomes made a lot of difference. So mostly about poisoning and non-communicable disease like stroke and epilepsy and hypertensive emergencies, we could make a lot of difference. And these are the numbers that we were managing. So, and also through this two-way communication, we could also enable a lot of procedures by these peripheral doctors, like intubation or a central line placement or an ICD placement also. So these are a few pictures about training. And these were the KPIs with which we started, and we were able to achieve almost 80% of the KPIs that we started with. So the referral rates had come down, the mortality had come down, and also the occupancy of the beds and the usage of the facility had improved after we started this EICU program. So, and also we were able to do some thrombolysis for some of these patients working remotely with them. The major challenges are that the system or the database has a facility for HL7 interface of the monitors, but then we couldn't do it because they were not supportive. And also recruiting and retaining the health professionals was one of the major challenges that we had. So the benefits that we had were improving outcomes and also reducing the costs. So this actually, the program has a wide chance for scalability to different problems, not just for stroke or epilepsy, but also probably you can also look at chronic diseases coming into the system through the use of this EICU. And if we can cover more areas with this, right now we are doing about 8 centers with about 4,000 patients in the last 1 year. Probably the scalability in terms of numbers is also there for this, and I request the key policymakers to look into this possibility of expanding the concept to other areas as well. And because we can generate a lot of database and data is power, there's a potential for collaborative research, especially for rural health. So there's a lot of future for this model of hub and spoke for emergency medicine and critical care. So what we have made is just a humble beginning, and there's a lot of scope for way forward. Thank you.
Thank you so much. Thank you so much, madam.
Thank you.
For the want of time, I think we will not have any discussions. And I request all the speakers to come out to the dais to receive the memento on behalf of the organizing team. I also request the next session to be started off immediately after this, because we will break for lunch only after the next session. The panel discussion will begin with the panel discussion. And my sincere request, because we are running short of time, we will not have too much of discussions. We will have to go through 4 topics in this session. And also to inform you that the session on the Kerala experience has been cut short, and we did it as a parallel round table in another room. So that has also been completed. So this will be the last session for the day.
Thank you, sir. I now request the chairpersons to hand over the certificates and mementos to the speakers. I invite Dr. Praveen Agarwal, sir, and Professor Dr. Padmaja Durga, ma'am, to collect the certificates and memento from the chairpersons. We welcome Dr. Srikanth, sir, State Nodal Officer for Trauma Care, to give the memento and certificates to the chairpersons. Dr. Shantimata Lamaringam, Brigadier Dr. Venkatanarayanan, sir, and Dr. Vichnathan KV, sir. We invite Dr. Srikanth, sir, State Nodal Officer for Trauma, to give the memento and certificates to the chairpersons. The lunch will start after 30 minutes. We are starting off with the next session. The next section will be on registries in emergency and trauma care. The chairpersons for this session will be Dr. Abdul Rashid, Special Officer, Director of Medical Education, Kerala; Dr. Bindu S., Superintendent and Additional Professor in Pediatrics, SIT Hospital, MCH Trivandrum; Dr. Noble Gracious, Professor of Nephrology, Medical College Trivandrum; and Dr. Anil Satyadas, sir,
conduct the panel discussion on trauma registry. The participant panelists are Dr. Sriram Sistla and Dr. Vinod Menon. Over to you, Dr. Amit.
Thank you, respected chairpersons. The panel discussion on trauma registries will begin now. I would request Dr. Sriram is here. Sir, could you actually come over? What I'll do is that I'll just set the ball rolling for this panel discussion on trauma registries by giving a small presentation on what has been happening in terms of trauma registries and databases in trauma care in the country, and how the Apex Trauma Center started its own trauma registry and where the country right now is, and what are the important tenets of the data points you need to collect So basically you could call it trauma registries, you could call it trauma quality improvement databases. The final result, what we want is actually we have to define what we want from our databases. And generally worldwide, the trauma registries are now being more and more called TQI databases or trauma quality improvement databases, because the final aim of these databases is to actually improve the quality of care which we deliver. I do not have anything to disclose. My talk outline will generally be, I'll skip the magnitude of the injury problem, we all know that. But what are the fallacies of the current data sources, and what are the data sources with which we are sort of projecting our trauma-related deaths? What are trauma registries? What do they mean? How are they different from other disease registries? And what has been the journey in India so far in terms of the research projects, in terms of a single center trauma registry which we had started way back in 2009? What are the lessons learned, and probably what we can give back to Kerala as a state in the coming years? And we've already started a national task force project. The ICMR has funded it this year. It'll be funding 8 more centers. So we'll look at that. But the problem is that injuries are there due to multiple causes, and it is actually a public health problem. But majority of these are transport related injuries. That does not mean that it is limited to transport related injuries. So our data shows that only 50% of the injuries which are coming to the hospitals in general or throughout the country are transport related injuries. But there is another 50% of injuries which are not looked at all. So I'll not actually go into the details. We all know the number of deaths. We all know the extent of disabilities these injuries are causing. But every possible data source or numbers which we are collecting right now, many of the studies conducted by international experts, by IIT Delhi, have shown that we are underreporting our injury data. So we are grossly underreporting it. So whatever number of deaths you are seeing, the number of injured you are seeing is actually underreported. Again, another thing which is important is that the trauma centers or the hospitals are also getting flooded by a lot of non-fatal accidents. So one is the number of deaths, right? But more than that, much more than that, are the actual hospital visits of these injured patients. And we need to improve the quality of care of these patients rather than those who already died on the way or at the site of the injuries. And the numbers are phenomenal. To each death, there are approximately 15 severe injuries and up to 50 to 60 so-called minor injuries. So what are our existing data sources? So majority of the data which is being collected and projected here are either from the police database, which is the NCRB data. Ministry of Road Transport and Highways also collects some amount of data and publishes every year. The WHO injury burden reports are there annually or biannually, and 5 years. We have some data being collected through ad hoc projects throughout the country, and we are having that data. And now there is a National Injury Surveillance Center established by the Ministry of Health and Family Welfare at the RML Hospital in New Delhi. It is also encouraging other smaller hospitals to collect the in-hospital data. But what are the I would say limitations is that most of the focus of all these databases is the road traffic injuries. So we only have road traffic injuries, but the other lot of like unintentional injuries, agricultural injuries, interpersonal violences, assaults, they are completely, we don't have those data. Secondly, it also reflects the road traffic injuries. The current databases reflect only which have been registered as police cases generally. Therefore, there is a lack of in-hospital database dedicated to injuries or trauma. Then there is no pre-hospital data, tangible pre-hospital data. Most of the states which are now having PPP model, some amount of data is being generated by the service providers or the people who are actually providing the pre-hospital care. But again, the auditing of that data is a problem because that data is not getting audited. We are not getting anything tangible out of it. Then there is the lack of hospital-based data. We do not have outcomes. So we do not have stratification. We do not have codings in terms of severity of the injuries so that we can have policies or process changes to improve the quality of care. That's again a problem with the existing databases. We all know that trauma care is a systems issue, and therefore whatever collection of data should happen across the system. That means which includes things much before the hospital, and also certain things like rehab, whether or not the patient was given rehab or not after the hospital. So it is very simple to say that trauma systems should aim at getting the right patient to the right place at the right time for the right kind of care, where time obviously we've been discussing is the most sensitive, but to collect data across board is very difficult. Very difficult in terms of, and that to timestamp data, which is very, very important, is very difficult. In the trauma system maturity index, again, I could find one paper in which India still is at the level 1 or 2, which is nearly primitive trauma care systems. And here trauma registries, I have shown that it is still hospital based, certain hospitals collect it, some hospitals don't collect it. So it is still not a unified database which is coming out from the hospitals. We all know that if we want to improve the quality of care, we need to assess our structure, we need to assess our processes, and finally compare it with the outcomes of care which we are delivering in terms of trauma care. Can we measure these things? Yes, we can measure these things. We can measure the structure, which is generally the role of the policymakers and the government who is actually providing that structure in terms of the number of pre-hospital care ambulances or the number of trauma centers, the number of doctors working there, whether they are trained or not. So that produces a sort of a structure which we can actually measure. We can just pass on the checklist to the Directorates of Health Services and know what kind of structure exists, which already Niti Aayog and AIIMS Trauma Center, Dr. Bhoi had done a lot of research on the existing infrastructure of the trauma centers. But what we have to concentrate, if we have to make a robust database, in-hospital database, is measurement of the processes of care. And that Dr. Akshay made my life very easy by saying that we need to have timestamp data. Unless we have timestamp data, we cannot sort of improve, and secondly, we also cannot benchmark a particular trauma center or a particular state with other states. So that's very, very much required. And finally, we also need to train the people who are keeping these trauma registries in various things like the trauma scoring systems, because ultimately you have to stratify them. Not all patients will do well. Patients with severe disease or severe injuries will do poorly. So we have to compare apple with apple, and therefore we have to train the HR manpower if we want to have a really good database. So trauma registries are basically tools for improving quality of care. That should be our goal finally, to improve quality of trauma care which is given to the injured patients. A brief history: it started in the US as a single hospital registry at the Cook County Hospital in Chicago, and thereafter it was made a state trauma registry, and then finally in 1993 we had the American College of Surgeons National Trauma Data Bank. And even in a country like US in 2022, there are about 4 or 5 states which do not have trauma registries. So that's what I want to highlight, is that we need to sort of sample them in the state, or implement them into states or hospitals with caution, because ultimately there's a lot of manpower training, there's a lot of money which is involved. So trauma registries are not only registries which would tell you about where it happened, how it happened. The surveillance registries can do that. What trauma registries in effect are actually also discussing the processes of care, and that's why they are also known as clinical quality registries, not only clinical registries or surveillance registries. So what is the best place to capture that data? A little bit of pre-hospital data, a little bit of post-hospital data, and we have learned lessons from various programs and various research projects that within the hospital is the exact right place where you can collect both what had happened before the patient came to the hospital and after the hospital, right? So that is the place where the trauma registries should be actually established, and I'll come to why should they be established at the tertiary care centers. Now, as I said, surveillance registries or other disease registries are slightly different from trauma registries because they do not include timestamping, and timestamping is a big bottleneck in having a robust sort of database, because it involves a lot of manpower. So why should we, as I said, trauma registries cannot be implemented in all hospitals, so we have to begin somewhere. So what are those hospitals we should begin with? And they, in my opinion, should be the tertiary care hospitals. Why? Because ultimately, the most sickest patients will find their way to these tertiary care hospitals anyhow. Whether they are direct, which we call primaries, can come to the tertiary care hospital, or there are many smaller level hospitals, and we just now had a presentation from Thai also, that many of these patients would be treated in smaller level hospitals, but finally, eventually, they will reach the tertiary care hospitals. So, if you want to collect a database, the tertiary care level 1 hospitals or tertiary care trauma centers are the one we should begin with, smaller steps. Secondly, there's a high mortality in the first 24 hours, and these sick patients we need to analyze the database of these sick patients. Anybody having a fracture both bone forearm or a minor fracture to not having any serious illness, we need not keep them in the database, because ultimately, they're not that sick. So we'll not be improving the system by analyzing data of these patients. And we all know green patients are like 70 to 80%. So we will actually not analyze that particular data, only we'll try to analyze the data of, say, the red patients or the yellow triage patients. Why tertiary care centers again? Because their infrastructure, manpower and research commitments are definitely more, and they would be sort of local regional resource centers for other smaller medical college hospitals to further develop their trauma registry. So we want to focus right now on tertiary care hospitals. So how to start a trauma registry? There should be a custodian, there should be somebody as a nodal officer or in charge of that registry program in that particular tertiary care hospital. We need data points and which are defined till the end. So we need a data dictionary basically. Then we need to decide what kind of data we are having. So it will be a combination of real-time data, because it has to be time-stamped, and some of the data from the hospital records has to be abstracted. The data quality needs to be maintained, because we have seen over the years that there are so many missing data which are not there. There are critical data which are missing, and therefore there is somebody who needs to be a data manager and needs to be trained in actually picking out the missing data and then again filling it up. Security is very important, and therefore de-identification, that means compliance to confidentiality of this, because most of them are medical legal cases. So what we do and what are the international best practices is that whenever we have a registry database, it is analyzed and summary statistics are provided to the policymakers or to the hospitals. No amount of identification goes into the data. The whole data is based on registry numbers, no hospital ID, and that's why we have different servers for the trauma registries, and they are not a part of the hospital information system or hospital servers. So our journey so far, basically we started at the Apex Trauma Center in April 2009. We made tweaks and changes in our data forms in 2010. We keep on editing our data sets. So it's not that right now whatever trauma registry form we are having is the same as 2009. It has been really pruned down, because there are many data which we felt were not providing any information regarding the quality of care, and therefore we just removed them. Who collects the data? As I said in the morning our trauma nurse coordinators are the pivot around which the emergency care and the patient care handle. So they are the ones who would collect the ED data and follow the patient through with that form into the hospital and also till the disposition. How does the form look like? It is very simple. Most of them are check boxes. So they just have to tick mark, and then later on we have developed a software for it, and they put it in the software when they're off duties, off ED duties. But again, as I said, there are separate servers for the registry because of confidentiality issues. There were major research into trauma registries and trauma systems, of which we were a part as the Apex Trauma Center. I'd just like to mention two major of them. One was the TITCO project, supported by the Tata Institute of Social Sciences, Mumbai, and the AITSC, or the Australia-India Trauma Systems Collaboration. And we did significant work there to actually prune down the database, or make the essential database for the country. Now, TITCO project was principally worked on a pilot project to start trauma registries in smaller hospitals or, tertiary care hospitals, but around the country. These are the listed hospitals which we had. Then we had the 4-year running Australia-India Trauma Systems Collaboration Project, which basically was not only a trauma registry project, but also trauma quality improvement projects, and it had other interventions also. And therefore, we started collecting data and knowing the minimal data set as to how the minimal data set should look like. We had many registries. We had the WHO minimal data set. We had our own registry. Various hospitals which were engaged in this project had their own sort of data sets. So we amalgamated all of them, and we finally, out of 130 data points initially, we sat down over the years and pruned them to about 72 essential data points, which could cover most of the key performance indicators which are required to assess a system or trauma system. So the lessons learned were, it cannot happen without money. So you might have ad hoc projects, but if you want to sustain that registry, you need to have certain staff which is designated for that particular trauma registry. You need to have data collectors who are properly trained in maintaining the data, and especially because these are time-stamped data, you need to be in the ED, somebody needs to be there assessing what is happening and ticking that checklist or checkbox as the time goes. Just by, and we tried it in district hospitals. One of my PhD students actually tried it without a dedicated manpower. She just handed over the trauma registry forms in a smaller district level and rural hospitals. It will not happen. You will not get the data or registry data from smaller hospitals, even if you have, sort of give them some incentives. But the main problem is that at least at tertiary care hospitals, we can dedicate some staff from our regular staff into registry, and the TNCs are the best to do it. Start small, start with single big centers, and then probably go on and then elaborate it to the other centers. Then again, we need to know what we are collecting, so don't collect a lot of data because it does not mean anything. Rubbish in, rubbish out. So just collect the data points or data sets which are essential to assess the quality of care across the trauma systems. We had a few publications. There are, I think, 9 listed, but now we have published the 10th publication from the AITSC data set. So you can imagine that data is very important, not only for improving quality, but also a lot of publications will be there. Your data will be shared by other people, and then finally benchmarking can happen. And finally, I wrote down a project which has now been taken up as a National Task Force project, relating the trauma registry or trauma quality improvement database to actual trauma quality improvement program. So this will be the next 3 or 4 years. We will run this program as a NTF project, which will study the effectiveness of TQI programs, obviously based on the database we collect from the registries. There will be 8 centers. These are the centers which we and ICMR together, sort of decided. Some of them are AIMS. From the south, there is JIPMER. There are other centers also, but this project is very open. If the state can sponsor any one hospital, we'll be more than happy to take them on board and make another spoke here to develop the capacity to run a trauma registry and also to run trauma quality improvement programs. This is the operational model. We at the Apex Center and the ICMR would be the hub, and then there are these 8 other centers which we plan to develop as regional resource centers for trauma registries and trauma quality improvement. So the way forward, this is the final slide or maybe penultimate slide, is that we have to link the databases in trauma care to the quality improvement programs. Unless we do that, I do not think much will improve in the future. Then we have to initiate it region-wise, and Dr. Ashil also said what a region means is a definite geographical area, maybe a state, maybe a portion of the state. We have to start small. We need to have a dedicated and trained custodianship. Manpower is very important. Manpower training into upkeep of this registry is very important. Otherwise, we actually had this AITSC registry and TITCO registry. we maintained it till the time the project was going on for 4 or 5 years, and then it stopped because there was no manpower. So I think we need to see the sustainability also. And Thai, I think, did a very good job of incorporating the registry into their systems. But again, how much it is collecting timestamp data, or how much they're trying to improve the quality of care will come only after 5 to 10 years when they start comparing their year-to-year data. Finally, this is my way of looking at the goal of quality care in trauma. So we begin with basic trauma care or optimal trauma care. That requires a structure. That means some provision of a trauma center or good emergency rooms. And manpower is very important in these emergency rooms, who will take care, or dedicated manpower. To make it more efficient, right, we need processes of care. Until unless we incorporate the processes of care, even trained manpower will not be able to help. So if we want to make the system efficient, we'll then have to probably go into protocols and protocolize care. Finally, we have to monitor and analyze these trauma structures, and that's the responsibility of the government and the policy makers, to continuously monitor whether or not the structure they have provided in terms of trauma centers, in terms of the manpower, is actually there or not, whether they're functioning in a proper manner or not. And finally, we have to monitor and analyze the processes of care, and that's the role of the TQI databases or trauma registries. And if they don't do that, I think they're meaningless. So we have to monitor the process of care. Only then probably we'll be able to reach that point in which Western trauma registries have gone, and now they are benchmarking their trauma centers according to the data which the trauma centers are collecting. And that has to be done across the board. That has to be done in pre-hospital care, in-hospital acute care, and in-hospital definitive care. I think I'll stop now and invite Dr. Sriram to say, and these were my views about trauma registry and what we have done in the past decade or so. Any views from your side? Okay. Okay.
So can we get connected to Dr. Vinod Menon? He had been waiting to join. I think one is there.
Can you hear me?
Yeah, Dr.
Can you hear me?
Yeah. You are audible. Are we audible?
Thank you. Could I probably try to see if I can share my screen? Can you see my screen? If not, I'll ask Vivek to get my slides up.
Yes, sir.
Dr. Menon, can you share the screen now?
Yeah, I'll try that. If not, Vivek has got my slides, so he could do it. Let me see.
So we can't see your screen right now.
Just try it once.
Okay. Can you show my slides and I can talk to it?
Okay. Are the slides here? Dr. Menon's slide?
Just a minute. Wait a minute, sir. So, is your slide up right now? Yeah. So,
Dr. Menon, you are the host now. Try sharing it once.
Let me try now. Yeah. Can you see slides now?
Absolutely, yeah.
Okay. Let me bring it down. So you can see my slides. Can I start? Yeah. Can you hear me, Dr. Sriram?
Yes, sir. Loud and clear.
Yeah. Thank you. Yeah. Good afternoon, Dr. Gupta, other dignitaries on and off the dais, ladies and gentlemen. It's indeed a pleasure and a privilege to me for me to be able to join you today virtually from the United Kingdom. Personal and professional commitments and diary clashes have prevented me from being there physically. Trying to move my slides. Let me see. Yes, thank you. So I'm delighted that this KEMS summit is being held in my home city of Trivandrum, and you've all been to visit the Apex Trauma and Emergency Learning Center, a center that is very, very close to my heart, which was generated during the visit of a previous health minister to the United Kingdom, and close links with the University Hospital in Coventry and Warwickshire and the University of Warwick. And also, we've been in touch with the Consul General of India in Birmingham, who has been very supportive. And as Dr. Gupta was mentioning, the scope for huge collaboration between centers in the West, very committed clinicians, and to improve the course and the management of patients affected by multiple trauma, and with and looking at the registries. I mean, I picked this slide of the Transport Research Wing of the Ministry of Roads, Transport and Highways, which shows that the number of accidents a year, about 500,000 patients are injured every year, and there is about 150,000 deaths a year from road traffic accidents in India per year. And Dr. Gupta mentioned that this is only just the tip of the iceberg. There are other known road traffic accidents as well. So this is a publication in Lancet in 2020 from India, from the Department of Health, which shows that in 2017, there were 218,000 deaths from road traffic accidents a year. So the number of road traffic accidents is certainly going up. And we need to be really very quick in our response to this, and trauma registry is just a part of it. There is good commitment from the World Health Organization, who have really made the plea to develop national registries which will help to characterize the disease burden and identify high-yield mechanisms for improving the quality of care. This article is a World Journal of Surgery, which looks at the developed registries in the developed world and how those lessons learned can be translated into developing registries in developing countries. And there are a few lessons and a few principles we could learn from this. The United Kingdom is only 10 years ahead. It's not 20 or 30 years ahead. The reorganization of trauma services happened in 2012 with the development of 27 national training centers. But what has run parallel with it is the development of their registry, the UK registry, which is called the Trauma Audit and Research Network. It not only collects the data, but it also looks and analyzes the data and puts forward a lot of research themes. If you look at the cycling-related accidents, look at adolescent trauma, urethral injuries. So it looks at the whole concept and tries to develop research strands. This is the Australian Major Trauma Registry, and they looked and they confirmed that minor trauma accounted for the vast majority of cases and more than half of all the hospital inpatient beds. These are initial observations from the Australian registry. And if you look at the German data, we all know that a patient coming with multiple trauma needs a whole body CT scan. But very clearly, this shows that the routine use of the whole body CT scan is not superior to a combination of conventional radiology, ultrasound, and focused CT. So we could change the way we manage these things based on the findings of a validated registry. Dr. Gupta, I've read your publication, which came the World Journal of Surgery. I think it's a year before COVID, the joint work that you have done with the Australia-India Trauma Systems Collaboration, and looking at how well the data fields are captured. And you've done a fantastic work in Delhi, but my only comment about this is that I've just shown on the slide from the Department of Health that we have 500,000 patients who are injured every year in India. But the registry, the registry in Delhi is fantastic. It's the trendsetter, but it's captured about less than 5,000 patients in a year, which is the number of cases presenting to your department. So I think if we could quickly transform this fantastic development that you have done to lots of other hospitals, then we can develop a very, very validated national registry, and this would be a really good start. And certainly there's good evidence to show that this will help policymakers and have research dimensions. The one aspect that we have not touched upon, we touched upon pre-hospital care, intra-hospital care, but we also need to look at rehabilitation of these patients. There will be physical rehabilitation, there will be cognitive rehabilitation, and to develop trauma clinics and to collect validated data is very important. Dr. Gupta touched upon this, and I would not spend much time on this. I think he called the data dictionary, and I would rename it slightly differently, and I would say suggested minimum data set. And this would be something, keep it simple, as Dr. Gupta said, we could always expand as time goes on. But please bear in mind, we got to consider the rehabilitation data as well, because the patients need to be physically as well as mentally active to return back to the community. Most of these patients belong to the younger age group. The benefits we have already discussed, and I don't want to dwell time on this, but definitely it will influence capacity building and improve clinical care. As far as Kerala is concerned, we are fantastic in the sense we got one of the best maternal mortality, infant mortality, life expectancy, and literacy rates in India. We've got a very well organized health network. But bear in mind that the private sector has 70% of the facilities and 60% of hospital beds, and a large number of patients involved in multiple trauma do go and receive excellent treatment in the private hospitals. So even though the tertiary care center can be the main hub, we should make sure that we engage with all the major and minor health providers if we need to get a consolidated, validated database. And the ATLC in Trivandrum would be an ideal opportunity to provide the training opportunity. And we could look at funds, we could look at corporate social responsibility funds and develop good networking. So the way forward is that the government of Kerala, and I would very much welcome if Dr. Gupta would be kind enough and his team to consider the Kerala unit as one of their spokes in what he's just mentioned. And we could definitely link it to the national registry. Any number of national and international partners would be very keen to support. And I know that Dr. Sriram being here means that the Tata Trust have confirmed the full support. We need to have a concept paper identifying the minimum data sets and accepting that these data fields will increase with time, validate the data, collate it, validate it, analyze it, report it, provide educational support to the reporting and participating hospitals, and have an oversight and a governance committee with regular meetings. And I would finish off with this quote from the great Greek philosopher Pericles. This trauma impacts on young people's lives. Families are shattered, lives are lost. So what we could all do here by developing a registry and improving the trauma and emergency care is that we would leave behind something that is not engraved in stone monuments, but we can easily wove into the lives of others. And thank you for the opportunity. Thank you.
Thank you, sir. Thanks a lot. Thank you very much, sir. I think, sorry that we kept you waiting. It should be early morning there in London.
Thank you. That's okay. Thank you.
Yeah. Hope you will be on the line. Yeah.
I'll stay on the line. Thank you.
Are going out for a morning walk. I need help. So I'll make a beginning. I think Dr. Amit Gupta and Dr. Vinod Menon are very clear, and then they explained to us what is a trauma registry and what it is not, why a trauma registry, and how to stay focused on it. Make sure that you realize the benefits of it. So not without any reason, a body like World Health Organization has offered it free of cost for all the member countries to be able to register and utilize the platform which has been created. There need not be any investment, it is only a question of registering yourself, number one. And that was the national experience which Dr. Amit Gupta himself has shared. And he was absolutely, it was an elaborative lecture about everything about registries. And I'm really happy that the last point, I really appreciated the number of research publications that you can expect. And then emergency medicine recognized as a specialty, and where Kerala has made a tremendous progress, I think it's time that you take it very aggressively and move forward without wasting a day. Actually, in fact, under the program ATLC, as a direct initiative, we invested, actually we budgeted a good amount of, maybe a modest amount of close to around 40 lakhs, and for some reason we were not able to take it. And pandemic, COVID is one thing that it didn't allow me to travel down to Kerala. As I think Dr. Amit, you would agree with me that it takes, you need to have a personal commitment, interest, and sit down with people. And maybe I don't mind trying to be rude. There is no sanctity to data. Let us agree to the fact, especially in a public health system. And for me, when I realized that, wherever I went and then looked at some of these issues, I felt that data is nothing but a meaningful information. If I'm able to get some meaningful information, that is more than enough for me. I'll stick to that. Then I'm not going to elaborate on anything like something that there is a problem that can't be diminished considerably if adequate attention, support are directed to it. The alternative is a continued loss of health. That are what we had been debating since yesterday. And these are, I was trying to also try to look at the systems of care. We often talk about systems of care, and the semi-systems of care, for some reason, they have showed the way forward. I think time that we start looking at trauma systems of care. It is not just enough. An accident can happen right in front of the main gate of Trivandrum Medical College Hospital, or if the victim is unfortunate on the street side. Whichever place the patient goes, that's the first point of contact. It should be treated with dignity and care and appropriately. It all depends upon the knowledge and skills and the inventory that people have. There are constraints. So that makes a difference. How injured patients get care, that makes a difference. When you're talking about how injured patients are going to be treated, that talks about, you're talking about quality systems of care, clinical protocols, very important in the service protocol, operational protocols, and of course, cutting across all these things where you get all the information is the trauma registry. That's the reason that we are talking about it. Maybe we would have spent more productive time on that. Well, time is always a constraint for all of us. And I thought I will try to look at a definition. It is an organized system, and it uses an observational study methods, and it collects the uniform data that is understood by everyone across the systems, right from a primary level to a quaternary care level, a quaternary care institute like All India Institute of Medical Sciences. And the idea is to evaluate a specified outcomes and a population, and this population has to be defined by a particular disease, a condition, or exposure that serves one or more predetermined scientific, clinical, or policy purposes. That summarizes the whole thing. Maybe the definition is very elaborate, but I thought that whatever Dr. Amit Gupta has explained and Dr. Vinod Menon has contributed, this carries the gist of it. So it is up to the youngsters to have a serious look at all these things, read as much as possible about it. One hell of a material is available. It is up to you to take advantage. Now the data that we are trying to look at registries is a realistic data. We are not trying to look at something which we are not going to believe it. And this data will talk about timelines, response of in the EMS response, and the way the patient journey through the health system. Very importantly, you can pull out the clinical status and the transition of care from the hospital records if they are available. And definitely it also talks about the system response, the standard treatment guidelines and standard operating procedures, both clinically and operationally. You will be able to, through the data, you will be able to understand whether people have complied to it. There are standard treatment guidelines, not necessarily I follow. Possible that I don't know. Possible that I have not refreshed. Similarly with operational guidelines, They are all there, they're defined. But is it possible that you really follow them up? Are you really following it up? Are you documenting? The moment the patient has entered the health system, the initial clinical signs, and going by the international standards, once in 5 minutes the patient is unstable, you are supposed to capture the vitals. Are we doing it? I'm not sure. If not today, maybe tomorrow. So there are other data. I think Dr. Amit has already spoken about it, but the crash data, the condition, road conditions, especially when you are looking at road trauma, and the kind of the environment. When it's raining in a place like Kerala, where it rains like hell, and the visibility is low, and the road conditions are bad, the angular banking is not right, there are gridlocks. All these things, they will contribute to vehicular trauma. And not only vehicular trauma, even at an elderly population like me, prone for falls. Well, it is a repetition of whatever, it's a digital conduit. To in two words, a trauma registry is a digital conduit. It helps you to evaluate the activity of trauma. It facilitates research endeavors. And it prevents, of course, it will help us to look at injury prevention and then evaluate the systems. Well, I thought that I was expecting that all the things have been explained and all that. My idea is, when I met the health secretary around 6 months back, he told me, Dr. Rajan Kopragade was commenting on that, deliberating on that. He said, Dr. Sriram, the issue is, all of us, we know that to capture data, to arrive at a data, is not an easy task. Having said that, is it possible, can you think of an idea to pull out as much of information as possible, assuming that the doctors will capture especially data of the accidents, because all these cases, by definition or by law in India, they are medical legal cases. This is one instance where you can expect a better information and better data. So if you contribute to that point, that means we are able to arrive at least around 60% of the clinical data. And if we are able to capture properly, structure properly, come out with a standardized terminology across the system, and trying to go for a pilot, then from my side, I was just interacting with him and explained to him, sir, there are two kinds of things that we want to look at registries. Would you want to look at a population registry, or would you want to look at a clinical registry? When you want a clinical registry, is it, do you want to collect the data want to develop a registry for all kinds of emergencies? There are systems of care, STEMI systems of care, stroke systems of care, which Kerala is already adopting. Would you want to consider the so-called medical emergencies? Would you want to collect the data of that? Then he said, no, let's focus on trauma. Then if that is going to take up a lot of money, because we're running out of time in the program, then is it possible that we could focus on a particular issue, like a traumatic brain injury, or whichever is the commonest trauma, given the experience of Trivandrum Medical College. Dr. Amit Gupta has already shared that. People have tried, and also was looking at literature. African countries have tried. Pakistan, in General Hospital in Lahore, they have tried, and they came with very good results. So taking that account, when I explained to him, he called for immediate meeting with the health team and all that, we interacted. Well, I take it for granted that we made a beginning in Kerala. I think it's up to the team now to take it forward. So I was trying to explain to myself, more importantly, that's where I brought up the issue of trying to pull out as much data as possible from the health records. Call them electronic health records, which makes life much easier if at all we are able to realize those electronic health records. So there is a data which you can pull out from the electronic health records, and also data which is relevant to develop a trauma registry. And then you can call them as a deterministic data or a probabilistic data. Deterministic being then trying to match data from the medical records, but registries being anonymized where nobody is accountable excepting for the care that is rendered to the patient, how the patient has progressed, how the health, the outcome of the health and the transition of health care. So we need not worry to anybody, excepting that we are looking at the facts that have happened in the patient's journey while he is being taken care of, and the probabilistic thing where you are trying to look at a commonly available data to determine the likelihood of any two records from the compared data sets. When you are looking at that, that means we need to look at what exactly is the kind of data that you would want to look at. Now, this is just a snapshot which I borrowed from Agency of Health Quality and Research, HRQ, which is the federal government of the United States. It's a tremendous knowledge depository. There are 400 plus pages of document about clinical registries and all that. It took me more than 3-4 months to understand what they have written in that. So that is, I think, there is an invaluable thing. In the center, you will see that EHR had a data warehouse where the information is being pulled down to be able to collate and be able to arrive at combine both the things, internal registries as well as external registry. And for us to be able to comprehensively understand and using some automation, trying to come out or look at, arrive at analytics, and very important, some dashboard. So analytics and trying to analyze things and then using statistics and all that may be a big deal. But a dashboard, I think, it makes my life much easier for all levels of care. Well, these are even this is a part of the HRQ document. They were trying to share the knowledge which they gained from talking to and interacting with various agencies across the globe. These are the data elements which you can easily pull out from the electronic health records. And then this is a snapshot of the whole thing. I think this can be shared with everyone. You can go through the whole presentation leisurely and trying to appreciate it. And these are the standards. I think this is one thing I would want you to spend a minute on that. These are the data elements which are important for interoperability. Maybe these are the things that we can seriously pay attention and try to address them when we were ready to roll out registries. And the same thing about it. Yeah. In fact, actually, this is one slide, one thing that I really wanted. When we stepped into Kerala and ATLC, we thought this was the idea behind it. We found that Government of India has tried right from the, I think, the 9th and 10th 5-year plan to be, looking at trauma in a very serious in a way, where they look at number one, they recognize that they contributed, that they believe that capacity building is the one thing, is the mainstay of trauma care in this country, as is everywhere, any part of the world, which is relevant. And second one is the data part of it, where they want to develop trauma registry. And to that extent, there were attempts made, and I'm really happy that Dr. Amit Gupta has been leading a team and published papers on registries. So in the center, we try to look at the patient in the center, and very importantly, the continuum. The other day, I was talking to health secretary yesterday, and I was telling her, so patient may get into hospital and get treated, but the thing is the transition of care that's going to make a difference. Patients get lost in public health system when they move from one level to other level. So if a routine medical illness, people are lost, doesn't matter. Imagine a patient in an emergency, a critical condition reaching a hospital, is lost. I believe when I was a primary care physician, I was 45 kilometers away along with the population with whom I was living for a proper kind of a specialty care. So I was forced to think, either I treat the patient or I allow me to die on the street side. And I promised myself I will not allow it. And I would dare say, I don't mind even going to the records. We thrombolized 24 patients. And I lost only one patient without any laboratory. I only had the help from Apollo Hospital in Hyderabad, Nizam Institute of Medical Sciences, another 2-3 hospitals where I had cardiology friends, where they were helping me through the sky. So when that is the condition, so let it be a patient-centric, and where the time that at least in 2023, we should be looking at all the 6 pillars where you need to be focusing on capacity building, data, there is no research. That's the reason that data is a sacrosanct. You need to have sanctity attached to it. The documentation which we were trained as medical students and house surgeons and the postgraduates, that we used to write down the case sheets incomplete. I'm not sure how much effort is going nowadays, but life is much easier. You have tabs, you have applications, You have pick list, you need not write, their standardized terminology. It only takes around 2-3 minutes to capture medical record. If you don't want to do it, I think you are not doing the right job. This is one message I really want to pass it to the younger generation. And we have collaborations, and Tata Trust is, we came forward, we volunteered, we promised that we'd support a registry. I hope that this will be taken up very seriously. And very importantly, doing all these things, we also continuously, we have to pay attention to the kind of impact that any of these initiatives that we take up. COVID struck, again, we had a real budget, a good budget for impact analysis. Am I okay? This one, yeah. So we could not conduct the baseline study, but an impact analysis has been conducted by Indian Institute of Health Management Research from Bangalore. The document is available. I think that Viswanathan will be sharing with all of you and all. That will help us to understand what has transpired, what are the lessons that we have learned, and what exactly we are looking way forward. So once this is the rationale is the burden, and this is the impact that we are looking at, we thought that using the 6 pillars, paying attention to them, that will help us to utilize the resources optimally. Training, task shifting, and technology. That's the last 5 years and all that, wherever we went, whichever project we took up, Tatas, we are using these 3 other drivers. And then that they should be contributing the performance improvement and patient safety. Even the same so-called PIPs, that's what American College of Surgeons, Committee of Trauma contributes. And then our role as Tata Trust is advocacy. And we want to stay focused on or supporting institutions wherever they are, and whichever is the institute, in capacity building of emergency and trauma systems of care in public health systems. So I sign off on that note, and thank you very much, sir.
Thank you, sir, for your
Yeah, Dr. Sriram, I think we'll end the panel discussion for want of time, because I think there are other speakers also. If there are any questions, we are here only. We'll be open to suggestions and questions if they want to, if there are any pressing questions on trauma registries. Otherwise, we'll probably close the panel discussion. And I must thank Dr. Menon also. I hope if he is online, thank you so much, sir, for encouraging all of us from your side, and hopefully we'll meet soon.
Thank you. Yes.
Yeah.
Thank you, sir.
Thank you.
Thank you, sir. Now I request the chairperson to give the memento to Dr. Amit Gupta and Dr. Sriram Sisla.
I already have.
Thank you, sir. Thanks a lot.
Thank you so much.
Patiently waiting.
Dr. Sriram Sisla. Dr. Amit Gupta, sir. Now we have a lunch break. The other topics will be continued after lunch.
and some misconceptions were there will not be taken care of. So I start my presentation very quickly. So all you know that there is a big shortage of people, of the patients who are suffering for end-stage diseases, be it the liver disease, be it the kidney disease, be it the heart failures, and other organs. So these are the statistics which are showing. On the other hand, in the emergency, we are losing so many patients. This is the death statistics that 28 lakh deaths are due to cardiovascular injuries, 10 lakh deaths are due to respiratory diseases, and 11 lakh deaths are due to injuries. So these are the graphs which shows you that how the injuries, including road traffic injuries, what are the statistics which are available with us. And now here comes the other part of the picture. At the one end, people are dying because they are living with their organs failed and they are just losing their lives. At the other end are the people who are just dying on the roads in our emergencies, and they are, after the death, they are being buried. Or so what is the solution here? So if I look at the road injuries, road traffic statistics, 1,42,163 patients died due to road traffic injuries in 2021. Now, this is another statistics which is showing that almost 7 lakh people are dying in our emergency medicines, medicine departments in our emergencies per annum in India. So how is the picture? What is the National Organ and Tissue Transplantation Organ is for? Our first is stop the organ trafficking and the commercial activities related with the organ transplant. This is the fulcrum on which, this is the basic idea on which we are working. So what is our strategy? One is, the most important which we are not touching is that we need to decrease the need of organ transplantation. So what we are doing is we are coming up with coordination between various programs which are running to prevent the organ damages, just like National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke, to reduce the need of kidney, pancreas and heart-lung transplants. And then National Program for Control of Blindness and Visual Impairment. This is our focus area. First, to prevent the damage of the organ itself. Then second is to increase the availability. So how will we? By increasing the disease donation. Right now, if we look at our statistics, India is number 3 in the world as far as number of transplants are done in the world. We are number 3 only after America, USA and China. But when I look at my population number, we are doing very, very little. So other way around is, and maximum more than 80% transplants are the living transplantation. So my living people are giving organs to make other person live, whereas on the other hand, I am losing the patients in our emergencies, in our intensive cares, in our neurosurgical units, and we are wasting the resources there. So main purpose is that I want to increase the disease donation by increasing the transplants in government facilities. Otherwise, if one more statistics is that more than 85% of transplants are right now being done in the private hospitals. And what is happening is, there is two different categories very well defined in the society. Poor are the one who are donating the organs, and riches are the one who are taking those organs. So I want to make it as a level field. It will be only possible when these transplant programs are started in our public sector hospitals, and opportunity is vast. And Thirdly, and most importantly, is by increasing awareness in the society. And last but not least, increasing the capacity. I am very, very sure once we are 144 crore people in this country, even if 0.1% of people I am motivated to donate their organ after their death, I am sure that we will not be able to handle the donation activities. So I am very, very hopeful. So why I am standing in this conference, which is about the emergency medicine development and all those things, and I am talking about the emergency medicine. Look at the similarities. Both the specialties has limited time. We are dealing with the multiple stakeholders. Rapid transportation is the need in both of these systems. Then these systems, both the specialties need to be a societal movement rather than the only hospital-driven activities. Then prevention is a priority in both these. Unless or until we prevent these, prevention is a very, very important area in these specialties. And then maintaining the data. Both the systems are data driven, and unfortunately both the systems are not working on it the way it should be. And then there are big doubts whatever we are doing, what quality and what are the end results. So those audits are missing in both the areas. We need to create that audits. And both even medicine has a common motto to increase the mortality and morbidity. So, same transportation, preservation and maintenance, time, skill, teamwork, coordination, protocols, follow-up, rehabilitation is common between emergency medicine and organ donation. The teams are same. What are the teams? The teams are emergency medicine, surgeons, neurologists, intensivists, neurosurgeons, anesthetists, radiologists, lab medicine, nurses and technicians. Same team is working in both the programs, both the issues. Only thing is, and then what is the fundamental goal of medicine as a whole and of these specialties? To relieve the suffering and to extend the life. Suffering of whom? I am looking at both the parts. One is a person who is already dead, who is no more with us. We are spending resources on this at the cost of a person who is waiting for a ventilator and dying in an emergency, waiting for his turn to be on ventilator. One. Secondly, it is in India, it is not a patient, it's a family which is in the hospital. They are spending a lot of money for no result. Third is, whole family is sitting in the hospital waiting for the ultimate to happen. So they are also suffering. And same is the patient. We are just prolonging his life when we already know that results are zero. Extend the life of whom? Very clearly. If I start right now, while triaging what I do, I prioritize a person who I feel has greater chances of recovering. At the expense of the person whom I feel that my efforts are going to be fertile. Here, by looking at such person, if I give him another 48 hours, maybe even 1% of them can be saved, which we have thought that they are going. So I am going to increase the number of patients saved by the emergency department people as a team. And at the other hand, I will be able to save another people with the organ failure. One loss here is going to be life for another 6 to 8 people here. That is the opportunity. So I am very hopeful as our specialty of emergency medicine matures, we will recognize the need to do more than simply respond to acute illnesses and injuries, helping to optimize organ donation while maximizing resuscitation efforts for those who can benefit is a part of this mission. Now, I look at the conflicts. What are the conflicts? Because I myself have spent 30 years in emergency department looking at the people. And to be truthful, I want to tell you, 6 months back, I was of the opinion, why should I be looking at the persons who are already dead at the expense of the people who can be saved? But these 6 months have changed my viewpoint. It is not that. It is actually, what are the conflicts? Whether to give the preference to the dying patient or who has already been gone. Waste of resources on already dead. ICU bed allocation priority, whom to give the bed? To a already dead person or person who can be saved. All that, then my doubts were also there. Even after doing the transplant, what is the quality of the people who have been transplanted with organs? Are they living normal life? What is the quality of their life? And how long they are living? But these 6 months have told me, yes, our doubts are, these are just doubts. I have seen the people who are living with transplant after 20 years with us. Recently, I think 3-4 days back, our team has gone to Australia to participate in transplant games, international transplant games. I have met with those people. They live a healthy life. Gone are the days when we used to say that after transplantation, people usually die within 3 to 4 years. Now I have seen the data. I can assure you results are much more better than the before. So we need to look at it. So here is, where is the emergency physician role in this whole concept? I will like to follow the same sequence, triaging, save the one who can be, even put the effort to resuscitate who seems unsalvageable. I am sure that 1% of the patient will be saved whom we have given up also. And then identify the those who are gone. Why? Why I should do this? Rewards are very, very big. One donor can save the lives of 8 and improve the quality of life of many. As per the numbers, it go to more than 30. I skip other slides. These slides shows the international studies which shows the importance of emergency medicine in organ donation. Successful donations are more likely when potential donors are referred from emergency department. Emergency department referral for organ donation, more organ donors and more organ per donors. These are very clearly depicted. There are no doubts regarding these issues. The implementation of a multidisciplinary approach for potential organ donors in emergency departments have already been there. So what should be the best practice? Let us start putting our efforts. Let us go with the misconceptions that organ donation is a different specialty for emergency medicine. By synchronizing these two systems, it will be improving our mortality and morbidity in the emergency department itself. And even if we fail, I can still remember in the ICUs and in emergency, one death, even if we know that death is going to happen, demoralize the whole team. Unless or until you save 10 or 15 people, you don't come to that normal baseline. Here, once you recognize, even after the death, this person can be of use and can save 8 lives, it will give you a lot of satisfaction. protocols and all things I will be sharing with you. I think we are running short of time. I stop here. Thank you very much. I will just request you to change your perception. Please be part of this. Don't think that we are asking to kill the patients who are salvageable in order to save the patients who are already gone. No, it is not. It is the other way around. In the emergencies, if we put our efforts, even after the death of a single person, we can give life to the 6 to 8 more people. Thank you very much.
Thank you, Dr. Kishan Kumar.
Now we can go to the next session. And I am inviting Dr. Thomas I, HOD, Neurology, Government Medical College, TVM, and Sir will give us an introduction to the stroke registry.
Good afternoon.
Welcome, sir.
Good afternoon, respected chairpersons.
Sir, can you please wait? Some faculties are waiting so that we can give the momentum. Can you please just wait?
Yeah.
Sorry, sir. I invite Dr. Kishan Kumar to the stage to facilitate the presentation.
Now I invite Dr. Manas Pratim Roy to receive the certificate and memento from the chairpersons. Now I invite Dr. Tajan PJ to receive his certificate and memento from the chairpersons. Now I request Dr. Cyril G. Cherian to receive his certificate and memento from the chairpersons. I request Dr. Jayakumar TK to receive his certificate and memento from the chairpersons. I request the chairpersons to be seated. Now we shall continue with our session. We will now have the talk by Dr. Thomas I, HOD Neurology, Government Medical College, Trivandrum. His topic will be on Introduction to Stroke Registry.
Good afternoon, respected chairpersons. First of all, let me thank Dr. Vishwanathan for giving me this opportunity. By this time, I think the importance of registry has been established. The definition has been told. We know that data is power, data is sacrosanct, and hence I think stroke registries are essential. Local stroke registries, national registries, international registries are all important. National registries are, the National Stroke Registry provides objective quality metrics, identifying and any potential implementation gaps. It helps in stroke management planning. The prompt patient transportation is assessed. The acute reperfusion therapies are assessed. The stroke unit hospitalization becomes widely acceptable based on this. The European Stroke Organization ESO program, the registry of, they have a stroke registry of stroke care quality. Actually, a year back we had been part of that, but we are no longer part of this registry now, because we have shifted our registry. And in that rescue, the inclusion criteria was acute ischemic stroke, intracerebral hemorrhage, transient ischemic attacks, subarachnoid hemorrhage, and cerebral venous thrombosis. An exclusion was patients less than 18 years of age. They looked at the stroke metrics. The lack of consent was an exclusion criteria. They divided their outcome into excellent and good outcome. Excellent when the MRS score is 0 to 1, and good when it is 0 to 2. So now we are part of the hospital-based stroke registry by the ICMR. We are one of the centers, and the rationale is to get evidence on access to stroke care in different treatment settings, which will help plan stroke management. The access to stroke care in one state may be different from the other state, one district to another. In difficult terrains, it may be even less. They look at the clinical parameters and outcomes of stroke, both in the acute setting as well as in the long-term setting. The rationale is to provide better healthcare delivery by looking at the data, to obtain better patient outcome, again by looking at our data, whether if we have poor outcome, we should have improvement and the quality improvement measures in place to facilitate preventive measures. For example, earlier on we had high smoking rates, and now the smoking rates are coming down. So we have to look at what is the risk factor which we can intervene on to improve the healthcare policy regarding stroke for the administrators. The main objective is to look at the pattern of stroke, whether it's hemorrhagic stroke, which is more common, or ischemic stroke. If it is ischemic stroke, whether it's a large vessel disease, small vessel disease, cardioembolic, or undetermined origin. The pattern of care, whether we are able to give thrombolysis in the acute setting, thrombectomy where needed, etc. The inclusion criteria for our the hospital-based stroke registry was first ever and recurrent stroke cases, both ischemic, hemorrhagic stroke, and subarachnoid hemorrhage, and those stroke patients presenting within 28 days of onset. We excluded transient ischemic attacks and stroke mimics. We looked at the clinical presentation, also the imaging both CT and MRI based. Most often in our center we use CT angiograms for all patients with ischemic stroke. Data abstraction is from stroke cases from all the departments who are admitted. We get the data from the medical records as well as from the outpatient department. In the core form, in the real form, we have the patient identification information, but we are not entering that because our IEC, the ethics committee, have not allowed us to enter the patient identification. We enter the diagnosis of stroke, the basis of the stroke, The final diagnosis at discharge, the type of stroke, I've already said whether it's ischemic, hemorrhagic, if it is ischemic, whether it's large vessel disease, small vessel disease, cardioembolic, etc. And the symptoms and signs are recorded. The severity of the stroke is recorded based on the NIHSS score. Imaging both CT plane and CT angiogram, and in some certain cases we do MRI, very few cases. Most often we do CT and CT angiograms. The risk factors and comorbidities are recorded. Details, whether it's thrombolyzed or patient underwent decompressive craniectomy or patient was sent for thrombectomy, was noted. The status of at discharge, whether alive or dead, and the functional status, the MRS score, the modified Rankin scale was recorded. The follow-up status at 28 days was also noted. Vital status and death, the cause of death in case of acute stroke was also recorded. The data is entered in an online software. We can get summary tables and reporting, which can be used for our own quality improvement as well as for publication. As soon as we have a stroke registry or somebody is looking at it, definitely our quality is going to improve. Even before we implement the quality improvement measures, when somebody says that you are going to be monitored, our quality is going to improve. All registered cases will be followed up for 28 day and 3 month outcomes are measured. Discharge case will be followed up by a social investigator according to the ICMR, but we don't have a social investigator, we ourselves do it. We get the collaboration of all the residents, even the nursing staff, the nursing students, and the nursing faculty from the adjacent nursing college. So the role of the participating center like ours is to collect data, collate data for stroke. Data entry is through online. There is periodic meetings with the IC workshop. Check. Periodic workshops are there. The expected outcome is whether we have thrombolyzed patients who come within the window period, where the patient is able to access the stroke unit in time when they come to our hospital. The discharge, how we have explained things at the time of discharge, whether pharmacological and non-pharmacological measures have been told in detail. For example, the importance of monitoring and reporting adverse reactions, also the lifestyle modification to be made, etc., would be emphasized at the time of discharge, and that will be recorded. The IEC approval was obtained, and the NCDIR will not be sharing the data to other institutions. The participants will be abiding by the ICMR NCDR policy and data processing. Let me stop here. It was a big learning for us by entering into this registry, because we were being monitored. We became more alerted. Thank you.
Thank you so much, sir, for an excellent talk. And sir has clearly described about the importance of registration. Sir, please.
I request the chairpersons to hand over the certificate and memento to Dr. Thomas.
I also request Dr. Ravindran C. to come on stage. And I request the chairpersons to hand over the memento and certificate to Dr. Ravindran C.
Now I invite Dr. Sujata Swarabhai, Consultant and Professor Plastic Surgery, Safdarjung Hospital, to speak on the topic Management of Burns Injuries and discussion on national policies. We welcome you, ma'am, onto the stage.
A very good afternoon to all, and I'm very grateful to the organizing committee for inviting me to talk on this subject of management of burns and the national policies for the burn injuries. Because burns is a trauma which is most neglected in most of the emergency departments, and most often the burn patient is kept in the extreme corner room of the surgical emergency in an attempt to isolate the burn patients so that they don't get infected. So where do we stand today? Just run the video when I ask you to. Sure. Yeah. So that's what the title of my talk. And burns, as you all know, is defined as a syndrome of both the local and the systemic manifestations due to any energy source. Injury due to any energy source, which could be either heat, it could be electricity, it could be radiation, it could be acids, anything. And if you see this data, which is taken out from the NCRB data, the causes of unintentional injuries during 2016 to 2021 has shown that burn trauma is the 6th common cause of trauma injury, and its incidence is reducing over the years. But what about the intentional injuries? What about the acid attacks? What about the homicidal burns? What about the blast injury cases? These are not documented in the NCRB data. So according to me, this is a grossly underestimated data, because this has been taken only from the major fire-related deaths and from the cases which are medico-legal cases. But it does not include the minor burns who are not admitted in the hospitals. And many of the patients, in fact, don't even reach the hospitals because they are treated by quacks in the villages and in the small towns. And also there are many seasonal variations which are not accounted for in this data. Like in Diwali, we have firecracker injury, we have diya burns. In monsoons, there's a high incidence of electrical injury. In winters, there's many cases of bonfires, electrical injury, etc. So according to us plastic surgeons, we have this data published in the Indian Journal of Plastic Surgery by our patron, Dr. J.L. Gupta, according to which we say that burns is the second most common form of trauma following road traffic accidents, and that out of a population of 150 crores, the incidence of burns annually is about 60 to 70 lakh cases, and the mortality is about 1 to 1.5 lakh cases annually. So the need of the present time and the need of the future is to have a national burn registry which will tell us the exact load of burn injury in our country, and also that when we develop the prevention strategies, how effective they have been. So if the death due to the burn injury, and in cases where there is no death, but there is disability, which is quite evident in these cases, photographs shown to you, which shows very grotesque deformities. Burns is largely a preventable disease, especially if we give timely and appropriate treatment by trained personnel, healthcare personnels. But there are lots of gaps and challenges, mainly because there is a lack of guidelines for a proper burn care for rehabilitation. There is a lack of research on risk factors, lack of effective policies for burn care, lack of available data, and hence there is a lack of burn prevention strategies. If you see this map, which is there in the website of National Association of Burns India, it shows that there are 60 burn units. And of these, there are only 27 units in the government tertiary centers and 33 units in the private sector. But most of these units are only in the bigger towns or the state capitals. What we need is more of accredited burn units at district level with a trained staff. So the government has done a little effort. In 2010, a pilot project for the prevention of burn injury was started by the Ministry of Health and Family Welfare, which involved 3 states and 6 districts where they wanted to start the burn units. But later in 2017, this was clubbed with the National Program for Prevention of Trauma. And the aim of this program of National Prevention of Management of Trauma and Burn Injury was to reduce the incidence of burns of all kinds of trauma by the prevention strategies. And for this, the ministry had held a meeting last year wherein several experts from different fields had a brainstorming session to formulate the strategies for prevention of the various kinds of trauma. So if we see the national strategies, we need to act at 3 levels. The primary level to decrease the load of burn injury, the secondary level which involves pre-hospital and hospital care, and the tertiary level which involves the rehabilitation, the physiotherapy, occupational therapy and psychological therapy of all the burn victims. So first, if we have to evaluate the burn injury problem, can we make burn trauma a notifiable disease? If not, then we should definitely have at least a national burn registry and a national burn injury surveillance system. Next is the prevention of burn injuries, for which we need education, awareness, providing safe environments, laws and regulations. And the education and awareness is regarding the prevention and first aid of burns, which has to be given to not only the children, school children, because they are the future of tomorrow, but it has to be the community at large, which has to be made aware about the preventive aspect and first aid of burn trauma. And also the healthcare workers, which includes not only the doctors, but even the dressers, the technicians, etc. So we have to also provide safe environment, and this can be provided by producing safe equipment by good engineering techniques and stringent rules and regulations, and these have to be enforced by our government. The emergency care involves the treatment, the referral and the rehabilitation, and we need to have national referral guidelines for the burn patients. For these, there should be a standard protocol for the transport of a burn patient from the periphery to the tertiary center, when and how. And also we should create awareness regarding knowledge of the golden period of resuscitation. So initial acute care of burns involves not only preventing the shock, but taking care of all the other associated problems. But how is burns trauma different from other traumas? Mainly because there is injury to skin first, which is the largest organ in the body. And apart from being a sensory organ and a thermoregulator, it is also a major protective barrier for our body. At the same time, all the systems of the body are involved, making it a generalized disease because there's systemic hypovolemia and that affects all the systems of the body. So whereas in the road traffic accidents, there is a loss of blood from the traumatized tissue and the patient recovers following the closure of the wounds, and the golden period is first 6 hours. Burns, on the other hand, involves loss of plasma, and in this burns, the golden period of resuscitation extends from 24 to 72 hours. And patient recovers only and only when all the burn wounds have healed. Until such time, the patient is always at a risk for infection and is immunocompromised. Now, understanding the magnitude of burn injury load, our National Association of Plastic Surgeons had actually brought out these guidelines for the best clinical practices in plastic surgery. This was last year. And this also included the guidelines for the management of burn patient. And this was just so that we can standardize the management of burn injury in our country and provide the best and the most effective treatment to all our patients in a country which is already resource constraints are there. Now, because of these resource constraints and insufficient number of burn units, most of the minor burn trauma, they are not admitted. They are treated on OPD basis. But the moderate to extensive burns, because they go into hypovolemia, they require admission, and we need an organized system of care for these patients. So I'll just play a video. Can you run the video, please? Which will show how the patient is treated when the patient comes to our burn emergency. The patient is brought in an ambulance from a distant, a district level or a peripheral hospital, taken into the casualty. After being taken to the casualty table, first and foremost thing to be done is to start a peripheral line so that the IV fluid can be started on flow. Following this, the patient is also catheterized so that we can monitor the patient. And the area of burn injury is assessed and detailed, and it is marked on a Lunden-Browder chart, wherein the depth of the burns is also marked so that we know the management. Next, the burn wound is dressed. All the dead tissue is debrided. It is covered with a non-adherent gauze. Followed by the application of a thick layer of antimicrobial agent, and most often we use the 1% silver sulfadiazine, which is available, which is cheap, and it's easily available in all the peripheral hospitals, the secondary level as well as the tertiary centers, followed by application of gauze pieces. In the hand, gauze is to be inserted to keep the fingers separated. This is followed by application of a Gamgee roll so that all the exudates can be absorbed, and this is kept in place by a gentle compressive bandage. So the initial few 15 to 20 minutes, the patient has been started on an IV drip, catheterized, dressed, oxygen inhalation is started because this patient has the inhalational injury. After this, the patient is moved to the weighing machine where the patient is weighed with the trolley. This is very important because we have to calculate the fluid requirement, which depends on the weight of the patient. And then the patient is moved to the burns ICU, where the further management is done. This includes monitoring the patient in details, applying all the monitors, the SpO2 probes, the BP cuff, and all the vitals are monitored on a central monitoring system. All these patients require IV analgesia, which can be in the form of opioids or NSAIDs. Antibiotics are not needed in acute burns as a prophylaxis because burns is a sterile wound. But if it's an inhalational injury, patient needs to be cropped up and given 100% of oxygen. And in addition, we need to nebulize them with bronchodilators, steroids, mucolytics, and heparin. Fiber optic bronchoscopy, if available in the tertiary centers, tertiary unit, is the standard of care for the inhalational injury because many of the patients require early intubation and mechanical ventilation. But at times, if there is so much of severe edema of the oral cavity that patient cannot be intubated, then a life-saving tracheostomy is a must. Carbon monoxide is the most common gas found in the fires, and for this the treatment is to give 100% of oxygen. And if eyes are involved, as usually happens in firecracker injury or chemical burns, then ophthalmologist needs to take a look at the eyes to prevent further damage. A word about electrical burns, you can see that immediately when the patient comes, when we catheterize, the urine is very high colored because of myoglobinuria. And we have to really push in fluid till we can get a light colored urine. And we target a urine output in these cases to about 2 to 5 ml per kg per hour. Now, today the standard of wound care for burn wound is the tangential excision and skin grafting, be it whatever percentage. But generally we use it for the moderate burns, minor to moderate burns, whether it is 35% burns or it is 25% burns, the patient recovers in 2 weeks. Can you play the video, please? Or if it is a case like this, 45% burns, wherein the patient is excised within 3 to 5 days, and patient, you can see, has got very good mobility of all the body parts, scars are very well settled, and there are no contractures. And the patient is also happy, and it is very satisfying to the burn surgeon also. Next. But what about these extensive burns which come to us? They are so extensive that there isn't enough area for autograft. So herein comes the importance and the role of NOTO, because we need cadaveric grafts to save these patients. Today we are excising only minor to moderate burns, whereas the rest of the world is today even excising and saving extensive burns, even to the extent of 80 to 90%. But we are lagging behind only because we don't have cadaveric graft to our disposal. So to conclude, I would say that it is the systemic management of burn shock which is most important, followed by the local burn wound care. And early excision and coverage with skin graft is the standard of wound care for burns now. And for that, we need to promote the skin donations and the skin banks. And we need to have national strategies for the prevention and the management of burns. They need to be laid down, because after all, an ounce of prevention is better than tons of cure. So thank you for your kind attention.
Thank you, madam, for the excellent talk. Just out of curiosity, one question, madam.
Yeah.
When do you use albumin?
Sorry?
Albumin as fluid of resuscitation.
Yeah, see, albumin is a very good fluid for resuscitation of burns, because as I said, that there is loss of plasma. So the best fluid to replace that would be albumin. But the only problem is that albumin is very expensive. Okay. And it is not easily available in all the centers, in the periphery districts and everywhere. So the best fluid to use, which is cheap and reasonable and effective, is the ringer lactate. Oh. And then albumin has other problems also, because it causes extensive edema, which doesn't settle very fast. So those are the few issues with albumin. But if the patient, despite giving ringer lactate, many a times patient come to us very late. So if the patient is not, we are not able to resuscitate and get an adequate urine output by ringer lactate, by really pushing in fluid, then we do need to give the albumin to improve the colloidal oncotic pressure.
Thank you, madam.
Thank you.
So next invite Dr. Ram Samukh to talk about guidelines on the management of pediatric emergencies. Welcome, sir.
Please start this one.
Good afternoon, respected chairpersons and fellow delegates. Today I feel honored and privileged by the invitation to deliver a talk here in Kerala Emergency Medicine Summit. I am thankful to Dr. Pratim Roy, Manas Pratim Roy and Dr. Vishwanathan for giving me invitation to attend this summit. Today I am going to share my experience of management of pediatric emergencies with focus on recent guidelines. Pediatric emergencies are life-threatening emergencies, and they require immediate intervention by trained medical professionals. And they can involve various parts of the body in a child, from the chest, abdomen, to the cranial cavity and to the CNS system. So coming to the acute condition in children, they require immediate evaluation and diagnosis and warrant urgent medical and surgical intervention. Any delay in diagnosis and the treatment can cost a precious life. So, standard guidelines are very important in these cases. These emergencies may be because of the medical causes or because of the surgical causes. I am going to exclude physical trauma here. I am going to just touch it for a few slides because I think all pediatric emergencies can give lot of psychological trauma to the families, and moreover there is a monetary loss to the family also. Acute medical emergencies can include heart diseases, hypovolemia, congenital adrenal hyperplasia, thyrotoxicosis, sepsis, shock, etc. But I am not going to cover these topics here. Chest emergencies are life-threatening emergencies, and a simple chest X-ray can solve the problem and pinpoint the diagnosis, like pneumothorax, pyothorax or empyema, congenital diaphragmatic hernia, sequestration or congenital lobar emphysema, tracheoesophageal fistula with esophageal atresia, and foreign body aspirations. In tension pneumothorax, usually there is accumulation of air in the pleural cavity and it compresses the affected lung, and this presents with severe respiratory distress in a child with distended neck veins, shock, and then absent breath sounds. This requires immediate decompression of the chest by inserting a needle followed by chest tube drainage. In empyema, there is a collection of purulent exudate in the pleural cavity. As you can see here, on the chest X-ray, there is a obliteration of the CP angle and white-out lung. This is the very common presentation of empyema in children. And these can be managed by first chest IV antibiotics, chest tube insertion, and fibrinolytic therapy or decortication depending upon the severity. There are some medical causes of acute abdomen, and that should be ruled out before, because I am a surgeon. So we have to rule out medical causes here, like patient can present with pain abdomen in pneumonia also. And in children, most common is a mesenteric lymphadenitis, henoxylin purpura, gastroenteritis. Then urinary tract infection can present with pain abdomen. Simple constipation can present with pain abdomen. All clinical examination and history with anatomical details in the mind can clinch the diagnosis in pediatric patient, because they are not going to give you any history. So suppose there is a pain in the right lower quadrant, this may be because of the urinary tract infection, or if there is a pain in the right upper quadrant, this can be because of the gallstones or hepatitis. Similarly, coming to the abdominal emergencies, the history should be all clinical and radiological investigation should be correlated with the detailed history, either from the parents if the child is less than 5 years of age, or from the child if child is more than 5 years of age. Acute abdomen can present with pain, abdominal distension, vomiting, but in infants and children, they usually do not complain of pain. They usually present with irritability, excessive crying, lethargy, reduced feeding, vomiting, and abdominal distension. So detailed character of pain should be inquired into these cases. That makes the diagnosis more accurate. And in children, thorough physical examination should be done in a calm and quiet environment. Try to distract the child by your conversation or befriend the child. And in cold weathers, rub your hands to make it warm so that child may not feel it. And single physical examination will not be enough. It requires serial physical examination to arrive at a diagnosis, and in any case of abdominal pathology, rectal examination should be done except in cases of neonates. Initial assessment should be done by typical ABC, airway, breathing, circulation, and to assess the level of consciousness in the children. Oxygen by mask should be started if in distress, but for precaution that in congenital diaphragmatic hernia, oxygen by mask is contraindicated. Otherwise, the oxygen will go into the stomach, in the chest cavity, and it will further aggravate the situation. There will be more distress. So, in congenital diaphragmatic hernia, one should not give face mask ventilation. You have to insert the endotracheal tube and then only ventilate if required. Relevant physical findings like all vitals, pulse rate, pulse rate, temperature, respiratory rate should be noted. Bowel sounds should be noted whether they are present or absent, and abdomen for softness or rigidity. Signs of other infection like medical condition like otitis media, pharyngitis, pneumonia should be ruled out, and hernial site must be examined in all the cases. In general, common problems occur commonly, like intersusception occurs in the infants and appendicitis in a child. And in all the cases of children, differential diagnosis should be kept in mind, and all cases should be determined according to differential diagnosis of these children. And I want to inform that most abdominal pains are due to medical condition. About 70% are due to medical condition. Only 30% are surgical. Bilious vomiting in an infant point towards the malrotation of the gut. I don't know, being a general surgeon, how many of you are aware of this condition? There is a malrotation of the intestine in children. Any bilious vomiting in newborn or more than 30 ml gastric aspirate is significant and requires investigations. And bilious vomiting can be seen in intestinal atresia, stenosis, extrinsic compressions, or commonly in necrotizing enterocolitis. These are some of the clinical pictures in infant showing abdominal distension due to duodenal stenosis, hepatoblastoma, intersusception or intestinal tumor. These are some of the photographs showing abdominal distension in children in a 3-year-old child of annular pancreas, right-sided neuroblastoma, and trichovezar. Trichovezar is slightly rare in pediatric age group, but it can occur in children also. In adolescence, there are different causes of pain abdomen, like menstrual pain, appendicitis, strangulated hernia, urinary tract infection. Here one can see that in 14-year-old child presented with carcinoma colon, though it's very rare, and 18-year-old child with trichovezar. There are some other causes, rare causes of pain abdomen, like neurogenic bladder in children with posterior third valves or vesicular reflux. Habitual constipation is one of the common cause of pain abdomen in children. Then sickle cell crisis, idiopathic thrombocytopenic purpura, or neurologically impaired child. In abdominal distension, intestinal obstruction must be kept in mind because of all the things which are enumerated here: malrotation with volvulus, atresia, imperforate anus, intersusception, Hirschsprung disease, meconium ileus, fecal impaction. All these are very common in children and leads to abdominal distension. Other causes may be ascites, trauma, severe hypokalemia, NNEC, intestinal perforation, ileus, etc. Congenital intestinal obstruction may be intrinsic because of atresia, stenosis, meconium, ileus, etc. Extrinsic because of the malrotation, here Latz bands are there, volvulus, etc. And functional intestinal obstruction should be kept in mind. The most common condition in children are Hirschsprung disease. Acquired intestinal obstruction may be dynamic, as seen in postoperative intestinal adhesive obstruction, malrotation with or without volvulus. Adynamic may be in paratic ileus, necrotizing enterocolitis. So common rule is that higher the obstruction in the intestine, more will be the vomiting. Lower the obstruction in the intestine, more the abdominal distension and constipation. Vomiting in newborns and infants may be because of the several causes, common being the pyloric stenosis, intestinal obstruction, reflux in newborns and young infants. Older children may present with gastroesophageal reflux, obstruction, gastroenteritis, etc. Blood in the vomitus in newborn. The most common cause is ingested maternal blood. So one should be not much worry about this blood in the vomitus in a newborn. It may be drug induced. In toddlers up to 6 years or older, it may be because of the ulcers, esophagitis, or in older children, varices. Blood in the stool, again in newborn, it may be because of the ingested maternal blood. Necrotizing enterocolitis is other condition, Hirschsprung disease, or even in malrotation with volvulus, they can present with blood in the stool. And anal fissure is more common in infants, and in older children, mucus diverticulum, juvenile polyp, etc. can happen. Blood in the urine can be because of the urinary calculus, urinary tract infection, hydronephrosis, tumor like Wilms tumor. Wilms tumor can present with only hematuria. So workup will include all basic hematological and biochemical examinations, abdomen and chest X-ray, KUB, ultrasound being the primary imaging modality nowadays in all the cases. And depending upon the pointed towards the organ-specific investigation can be ordered like abdominal CT in case of Wilms tumor, technetium scan, barium meal follow-through, or DTPA scan. Initially, all patient requirement managed by basic IV fluids, nil only, NG tube aspirations. Now question is when to operate. If there is a vascular compromise because of the malrotation and volvulus or incarcerated hernia or non-reduced intussusception, ischemic bowel obstruction, torsion of the ovaries or torsion of the testis, they require immediate surgical intervention. However, patient can be managed by early intervention in cases of non-perforated appendicitis, tumors or intestinal obstruction. In cases of appendicitis, intussusception, malrotation with midgut volvulus, mucus diverticulum, earlier the diagnosis and earlier the intervention, better will be the outcome. Appendicitis is the most common abdominal emergency, and usually the diagnosis is made by history and physical examination, and rarely perforation occurs in first 24 hours. Other conditions, intussusception in children usually occurs around 6 months of age when the mother starts weaning the child, and then this is, we call it idiopathic intussusception. There will not be any cause found here, but when intussusception occurs in older children like 2 to 7 years of age, there may be lead points because of the mucus diverticulum, or maybe there may be polyps. So here the classical picture is of vomiting, pain and red currant jelly stool. Here this is a picture when one proximal bowel intussuscept into the telescope into the distal bowel and leading to the vascular compromise. These are the pictures showing the sausage shaped abdominal mass, red currant jelly stool, though it is described in the triad of intussusception, but it is rarely seen. And contrast enema usually stops at the site of interseptum apex, and it is known as target sign. These are some of the pictures, because the interception is managed initially by the reduction under fluoroscopic control, either using air or by water-soluble contrast material. We don't use barium enema nowadays because there are chances of perforation during this reduction of the interception, and barium may spill in the peritoneal cavity, and it will be very difficult to remove it intraoperatively. And so the most important thing, when you take these children to radiology department, you should keep ready your operation theater, so that in case of any perforation, you can immediately transfer the baby to operation theater. There are certain pitfalls that when, like in bloody diarrhea in interception, it may be because of the Shigella dysentery also. And but any type of blood in stool may suggest interception. Now coming to another condition, malrotation. This is also known as gut on a stalk syndrome. Malrotation itself can present with bilious vomiting, but once it is associated with rotation of the small intestine, that is volvulus, then this is emergency. Child may be irritable, abdominal distension will be there, and blood in the stool. So this has to be operated as soon as possible. And these are some of the pictures of normal rotation of the gut. Usually by 12 weeks of gestation, usually the gut place takes its position, that is the colon on the right side and small intestine on the left side. Here you can see the malrotation. Here you can see on the third picture there is a lats bands are there compressing the duodenum, and usually the rotation here is clockwise direction. So for the surgeon, it's very important when you go inside the abdomen, you derotate his anti-clockwise position. Otherwise, your vascular compromise will be more. So if the treatment is delayed in malrotation with medial volvulus, this will be the result. All the small intestine will be gangrenous, and you have to resect it, and the child will go into the short bowel syndrome. Surgery in malrotation is known as lats procedure. Now coming to the mucous diverticulum, it may present with painless blood in the stool, and it can be diagnosed by mucous scan, and there may be ectopic gastric mucosa, as everybody will know, and there is certain rule of twos. Every surgeon is knowing this, that it occurs in 2% population, 2 feet proximal to terminal ileum, and it is usually 2 inches long. Other condition, infantile hypertrophic pyloric stenosis. This is the only condition in pediatric problem where there is only one surgery, Ramstead pylorotomy, and that will cure the child. This usually starts in about 3rd week of life, and it can be diagnosed by good ultrasonologist, or if the diagnosis is in doubt, one can go for upper contrast study like gastrochondria. This is the picture showing Ramstead pylorotomy. Other conditions are esophageal atresia with or without fistula. These are very common in neonatal period. We treat about more than 250 cases of esophageal atresia per year in our center. These are the different classification. Usually this condition is treated by ligation of the tracheal fistula and end-to-end anastomosis of the esophageal ends. There may be imperforate anus in a child. This needs high divided sigmoid colostomy. In intermediate, there are 3 types of imperforate anus: low, high, and intermediate. In low ARM, one can get away with anoplasty, but in intermediate and high ARM, one has to go for divergent colostomy. And PSARP later on. What is PSRP? PSRP is posterior sagittal aneurysmoplasty. Abdominal emergencies always was a dilemma. Some patients, they respond initially to the conservative management. So it is difficult whether these children should be operated or not. So surgeon, as everybody knows, the surgeon, good surgeon is one who know how to operate, and the best surgeon is one who know when not to operate. So here this is the most important thing one has to keep in mind. And in cases of gas under diaphragm, in perforation, midgut valvus, interception, and where there is feculent vomiting, no waiting is justified. So to conclude, pediatric abdominal emergencies are challenging diagnostic entities, but one can reach the correct diagnosis by detailed history and proper examination. Gastroenteritis, diagnosis of gastroenteritis is always a diagnosis of exclusion. Before that, you have to rule out all the surgical causes also. Otherwise, misdiagnosis can lead to significant morbidity and mortality. Now coming to foreign body aspirations, this is 2-3 slides are there. This is one of the newspaper clips where in the first case, 21 months, male baby has aspirated almond and presented to us with respiratory distress. So we did rigid bronchoscopy and removed this piece of almond. In second one, there is a nail in the tracheobronchial tree, and that was there for maybe two months, and child was presented with recurrent cough only. And this is a story of a mother who lost her nose pin about 3 years back. Her child, 2 years back, her child was 1 year old when she lost the nose pin because it fell on the bed and child swallowed it. Unfortunately, instead of going into the alimentary tract, it went to the tracheobronchial tree. But there was no symptoms. So for 2 years, child was having some occasional cough. So going to some practitioner, giving some antibiotic and all those things. One day one pediatrician thought we should take one X-ray. When he took the X-ray, there was a nose pin in the left bronchus of the child. So I thought it is there for 2 years, so it will be difficult to remove. But as everybody knows that gold is an inert material, so there was no inflammation, no granulation at all. It was removed so easily. I thought that somebody has kept it just now only. These are this chest X-ray showing drying pin in the bronchus, and other type of pins, and that is one is screw, which was removed from the bronchus. This is the bronchoscope. We use rigid bronchoscope for removing foreign body, and that is the bronchoscopic view of the left and right bronchus, and groundnut piece seen in the one of the bronchus. These are different types of foreign body removed. Pen caps, almond peas, peanut peas, then these are the solid plastic materials. Thank you very much for your kind attention.
Thank you, sir.
Though I did not talk about any guidelines, because I know that whatever I have enumerated, there is no guidelines for that. Only this pediatric emergency has to be diagnosed early and to treat early. If we want to prevent it, we have to send request to the God only, that's all. Nothing, no other guidelines are there. Thank you.
I request the chairpersons to hand over the memento to Dr. Ram Samad sir and Dr. Sujata madam.
Dr. Sujata, madam. And I request Dr. Vishwanathan sir to hand over the mementos to the chairpersons, to the Abdul Rashid sir, to Dr. Bindu S. Dr. Noble Gracious, and to Dr. Anil Satyadas.
Good evening to all of you, and that brings us to the conclusion of the 3-day long workshop and summit, which I should say went off really well. Though there has been a delay today, we have been able to achieve what we could in these 3 days with a lot of deliberations, lot of interactions, and definite take-home points, and also for us as a state to build upon what we have achieved so far and the way ahead in emergency and trauma care. I should thank each one of you here, and especially the government of Kerala for having given the support, and all the international, national and the state level faculty and our own institute faculty to be here to participate in the event. And I should say that as a part of the valedictory function, we would like to have some feedback, one or two feedbacks from our eminent faculty about the program, and then we will go ahead with awarding the cash prize and the first prize for quiz winner. Poster presentation award is there, I think. So, and we'll conclude with a photograph of the faculty and the organizing committee. I request Dr. Vivek to come over and announce the quiz winner and also the process that was involved.
So good evening all. We have come to the last session of the entire conference. Now we are going for the presentation. The first presentation is with regards to the results of the quiz. So one very good point we saw over here was there was a very high competition among the different colleges. They were well prepared. They're reading through their textbooks and the necessary guidelines which is necessary. And the winner of the quiz, the first place goes to Dr. Krishna Kumar and Dr. Vinayak from Calicut Medical College. Please do come on stage. Second place goes to Dr. Arun S. and Ajmal from Pushpagiri Medical College. I think they have left. Now coming to the next session, which is the paper presentation and poster presentation competition. I wanted to tell one note that we had 37 entries in the poster presentation and 18 paper presentations, and all were excellent. And the difference between the first and second is just a 0.5 mark to 1 mark, but we need a winner, right? So I'm going to announce the awards for the best paper. So I'll go this time in the reverse order. First I'll tell the second place and then I'll announce the first one. So the second place goes to assessment of troponin I in acute decompensated heart failure by Dr. Arvind Srikumar. This paper is from KEMS. And the first place for the paper presentation competition is Pedestrian Injury Pattern and Profile in a Tertiary Care Center in Kerala by Dr. Harini Saubhagya. This paper is from Thrissur Medical College, Government Medical College, Thrissur. Now next is for the poster. The second place for the best poster award is Lessons Learned from 24-Hour Mortality Pattern in the Emergency Department by Dr. Harini Saubhagya from Government Medical College, Thrissur. And the first place is A Case of Swollen Hand and Unswelled Mind by Ashwath Raj. This is from Ikra Medical College. Thank you all, and thank you organizers for this great opportunity. Thank you.
Thank you, Dr. Vivek. And now may I request Dr. Sanjeev Boy to give his comment. And one from the postgraduate, any winner who can come and just give a comment on how the conference was. Anybody who is volunteering to speak, an opportunity for you because there is hardly about 30 audience here. You can speak anything, please come. And I would also like all the senior faculty to just assemble here so that we'll have a photograph session. I request Venkat Narayan sir, Sriram sir, and Praveen sir will come over to the dais while Sri Kumar Ravi, Dr. Akshay is. I request all the faculty to come forward to be seated, and all the postgraduates can also join us after the. Yeah.
Okay. So I'll just give 1 minute remark. Yeah. So, ladies and gentlemen, I think this is the, you can say, penultimate minutes of this conference as time matters. We really thoroughly enjoyed the hospitality of Kerala, and we also say big thank you to the dignitaries on the dais, my seniors, colleagues, and junior friends who are assembled here. And let me take the opportunity to, on this platform, to announce the next, events of this organization is the EM India, which is going to happen in Pune. It is in last week of August. So you are all invited to that meeting, including I spoke to Sriram sir and invited him for the representation of Tata Trust. And our global congress, which is the most Indian represented congress global, is the World Academic Council for Emergency Medicine, which is going to happen in November this year in Turkey. So I also invite you to Turkey. So we do have a global event annual. So these are the upcoming events which are going to come. And the outcome of this meeting was brilliant. Such a meeting has never happened in emergency medicine sphere for two things. We have been doing a lot of work on academic capacity building, policy making in silos within the sphere of emergency medicine and trauma. But this is one congress. We had emergency care system building parallelly going in hall, and in one hall the core teaching of emergency medicine. That never happened. We like to continue this, and as Dr. Vishwanath said, next year again I think the Kerala will be of emergency care system development in this part of the country. Thank you very much.
So thank you all. I think we'll have the organizing committee come for the photograph. Organizing committee, please. Meantime, I will request Sujata madam to come over to receive a memento from the organizing committee on behalf of the Tata Trust for all the effort that you have put in right from the beginning. And it's a great moment for us. And it was only possible because of your active involvement along with Sriram sir and also all others in the Tata Trust who have been part of this. Thank you very much. And I request our organizing team to come forward. All of us. You can stand behind us. We are leading now, you will lead later. Come. Postgraduates, please. Please come. എല്ലാവരും വരൂ. Our nursing coordinator and team also, we have a big team from Trivandrum Medical College who were there for all the 3 days of deliberations. A big applause to our nursing team also. Sriram, Mrs. Sriram, madam.
I think on behalf of all of us, the big round of applause to Dr. Vishwanathan and his team. Thank you so much for having us here, and it has been a wonderful experience, a brilliant teamwork, and we have never seen such a magnitude or plethora of people around from all over India and abroad being associated with one conference. Thank you, Vishu. Thank you so much for organizing.
Pushing these guys to